plasma light cause less hyperlactatemia, reduced bilirubin levels, improved albumin. And even in perioperative renal transplant patient, there is a risk. We talk about hyperkalemia occurring with ringer lactate, but perioperative renal transplant patient, the compared to all. Sterofundin I've almost discussed. Malate is this thing of all the studies that have been there, which are mostly single-centered RCT. Sterofundin and RL have been comparable except for perioperative pediatric patients undergoing major surgeries. So results from small studies in pediatric patients have shown better outcomes with use of sterofundin in pediatric patient. And to sum it all, unfortunately, there are no trials or no good quality evidence comparing one balanced crystalloid with another. Unfortunately, we are not comparing. And whatever studies that have compared, they are only comparing either the acid-base status or the electrolyte status. They are not really comparing any patient-centered outcome like mortality, length of stay, need for organ support. So what is the need of R is to actually do some of these good quality studies. And in a country like ours, we also need to be careful that plasma light is an expensive solution, and where cost decides a lot of our treatment options, we also need to consider that. So what is the take-home message? The take-home message is buffers play a crucial role in maintaining acid-base balance in the body. Different buffers have different characteristics. Choice of buffer should be tailored to the patient's specific needs and condition, and the optimal buffer for balanced salt solution is still under debate, and a lot of research is required in this regard. Thank you.
Thank you very much, Dr. Aparna. And it was a real concise and a very good talk on balanced salt solution and the exposure of these solution to the cells. So the next speaker is Dr. Manish Chauhan. Yeah. He is going to take up CRRT, which is very critical and is an integral part of nephrocritical care. Manish, please.
Okay. Thank you, sir, for the kind introduction, and it's good to be back, and thank you for the organizing committee to tolerating me again this year. So I'll be discussing a bit about the prescription of the CRT, a very specific part of CRT, a bit difficult to understand unless you've been doing it regularly, so I'll try to make it a bit practical as much as possible. We all know that we have various forms of dialysis that we use in the, do we have a pointer? So we have the different forms of dialysis that we have been using. Okay, pointer. So no worries. So we have intermittent dialysis, okay, the normal slide dialysis we do. The point of concern at this point of time that we're discussing is the center one. Okay, sorry. So is the CVA-HD, CVA-H and the CVA-HDF. Okay. Yeah. So we have very specific indications of CRT, and these are upcoming now as we go into more sicker patients, as we advance our knowledge of the intensive care and go towards precision medicine. So we have patients who have hemodynamically unstable, we need to remove fluid without causing further instability. We have hypercatabolic states, okay, fluid requirements are high and we need to remove the fluid, keeping the nutritive values in place, or especially in ECMO that we have been doing for the past many years. There are certain non-renal indications also, like in patients who have hypercatabolic states, higher lactic acidosis is there, sepsis is there, MODS, ARDS is there, or there is CHF, and you need to decongest the patient fully. So in this scenario, if I'll just rush through these things. So if a patient who is in multi-organ failure is hemodynamically unstable, we think of CRRT. And even if the patient is stable, but the main problem is a solute cytokine or a fluid overload, we again still can do CRRT under such conditions. Okay. So many studies have shown that all over the world, CRT is becoming the modality of choice, and almost 72% of the sessions in sicker patients are turning out to be CRT sessions. So before we go into the prescription part, we need to understand what are the various forms of CRT that we use in the ICU. One is the scuff, where solutes are not cleared. very slowly you just move the ultrafiltrate with very minimum solute clearance. Okay. Then we have the hemofiltration. So we need to understand the convective process that is involved, where a lot of, like almost a liter of plasma per hour is removed from the patient, okay, and is replaced by a certain fluid that we have decided that we will give, and along with that fluid the solutes are cleared. Okay. So this is called ultrafiltration because it is done under pressure and fluid along with solutes is gone. Okay. So unless we replace it with fluids, which we call the replacement fluid, if we don't give it, the patient will become hypovolemic. So a replacement fluid is given in this modality. Then is the, the conventional dialysis that we do, but here we do it at a lesser rate. No convection is involved, only there is a dialysate coming in a countercurrent flow. The blood is going in the opposite flow, and from a high concentration to a low concentration through a semi-permeable membrane. That is the definition we read in medical school. The dialysis is done. If you combine these two modalities, we have a CVHDF, continuous veno-venous hemodiafiltration. So there is dialysis with the dialysate, and there is ultrafiltration under pressure. So both of these processes are combined, and this is the maximum times that we do in our ICU, so that we get benefits of both of these modalities. Okay. So the spectrum starts from hemofiltration to dialysis. This is pure dialysis. This is a combination of dialysis and hemofiltration, and these are purely hemofiltrations. Okay. So a lot of things on our prescription depends upon the dialysate that we are using and the replacement fluid that we are using, and that is the crux to determine our dose and the prescription. So this is what a machine would look like. If you look at the machine, when you are doing a hemofiltration, okay, the blood is flowing from, let's presume, so you give something of a dilute fluid at the same rate at which it is being removed, and under pressure it is pushed out of the blood along with the solutes, and there is some substitution later on, and that goes back to the patient. So this is the effluent here. If you talk about hemodiafiltration, that is a combination of the dialysis and the convection. We have again the substitution fluid pre-pump, pre-membrane. Then we have the dialysate coming in, and both of these combined, that is the filtrate and the dilate is thrown out. This is the effluent here. Some post dilution substitution goes back. Purely hemodialysis, no addition before entering to the filter. Just dilate going in a countercurrent mechanism, goes out in an effluent, some fluid removal if you set in, and goes back to the patient. So this is as simple as I can present it in front of you. This we will discuss. So this is the schematic representation of a hemodiafiltration. Access. Here some anticoagulants are given before the pump. You have not yet entered the filter. Now to make sure that the blood doesn't clot inside the filter, you have to dilute it with the same amount that you plan to remove as an ultrafiltrate. This is the replacement fluid that we call. Then this is an effluent pump where whatever discarded is pushed out into the effluent bag, and this is a dialysate pump which goes into the countercurrent mechanism and is again pushed out into the effluent. So this plus this plus this and any fluid removal that you set is the effluent pump. Rest goes back. So what is the primary therapeutic goal? Okay, solute removal, fluid removal. Indication, okay, metabolic or fluids, as I said. Diffusion convection is the principal, and we need dialysate fluids and replacement fluids. Okay. So now coming to the core. This is what a prescription would look like if you think of putting a patient on a CRT. Okay. We won't be discussing all of them, but the pertinent parts. So you need to know what your access is, which filter you are going to use. Okay. This is most of the time standardized in a patient in the ICU. The solution for priming, and here we start. How much is the blood flow that you will set so that the patient tolerates the procedure well? What modality are you using? We said we are using CVHDF. Okay. What is the fluid loss rate or the fluid removal? What are the electrolyte collections that you want to see? What do you want to correct? The calcium, potassium, you want to correct the metabolic acidosis, you want to remove moderate side solutes, anticoagulation, and the dosing is then decided. So this will be the crux on this. So modality as access we know, anticoagulation, blood flow rate. Okay. Ultimately what we need to do, or what we are planning to do, is to calculate what my dose of the CRT is going to be. So the effluent rate divided by the patient body weight is my dose. So our next few slides will be on how do we collect the effluent rate and calculate the dose of the therapy. in the end of the lecture, this is what we'll be looking at. So no need to be getting confused at this point of time. We will take them one by one. And this is our final calculation of the dose of CRRT. So let's talk about the blood flow rate. Blood flow rate is generally around 150 to 200, max around 300 ml per minute. This is a very slow rate. That's why it is called a continuous renal replacement therapy and causes less of disturbance. Second is the dialysate or the replacement fluid that we give. Let's talk about the first point is the replacement fluid. So as the word suggests, you are replacing the fluid that is being removed along with solutes by the dialysis machine under pressure. Okay. And this is where it is given. So this is what you have decided. So here I have decided that I am giving a citrate rich fluid along with sodium to act as an anticoagulate. This is the rate that we have decided, around 1 liter to 2 liter per hour. Okay. And this will be given as replacement, and an equal amount will be thrown out. This is QR here. Okay. This is the one of the components of the effluent rate that we are calculating. And this is the array of replacement fluids that we have, depending upon what your patient needs or doesn't need. If you don't want to give citrate, you can give citrate free fluids. You want to give citrate, you can give citrate rich fluids. What is the potassium that you want? You want a potassium free one, or you want a normalized potassium one? Okay, calcium, sodium. Okay, bicarbonate value, we have a standard bicarbonate one. If you have severe metabolic acidosis, you can give a high bicarbonate one. So this prescription again decides, the patient decides in fact that whether you want a low potassium or a normal potassium, you want a normal bicarbonate, lesser bicarbonate, what is the calcium amount that you want, whether you want citrate anticoagulation or not. So this is all decided by the replacement fluid, because you understand that this is going into the filter. If I don't give this, the blood will clot in the filter. The citrate needs to be in the filter to act as a local anticoagulant. We dilute the blood so that it doesn't clot, it flows well. That's why the replacement fluid generally is given pre-filter. So we dilute and cause a decrease in the hematocrit. The flip side, your efficiency will go down because it dilutes it. But that's why we balance it out so that it doesn't clot, but it also doesn't act as at a very low efficiency. If you give post replacement, you will have the same effect. You won't be causing any hypovolemia. You would be preventing the efficiency from going down, but the problem will be the blood will be concentrated because you haven't diluted it before removing the fluid from the filter. So the filter will clot. So generally we prefer giving majority of it pre-replacement and a small amount post-replacement, mostly to vent out the air. Okay. The dosage standard as per the guideline of the replacement fluid is 20 to 25 ml per kg per hour, which comes around a liter, half liter, or maximum 2 liters in average size of adult. And obviously then you have to calculate. If you want to remove the fluid, the replacement will be less, removal will be more to attain a negative balance. The machine calculates, it does for you. You just enter, I want a 50 ml per hour fluid replacement. So if the replacement will be a 50 ml per hour, less than that. The next part is the dialysate. It is a bit simpler than the replacement fluid because as dialysate pumps pushes in the dialysate, there is a countercurrent mechanism and it replaces, or rather it diffuses out whatever solute you want to remove. And this is where it acts. This is the composition, that a standard composition that you would put in with the sodium, bicarbonate, potassium, magnesium, or sugar levels, whatever you want to keep, and it is placed here in the opposite direction to the blood flow. Ultimately, it is again calculated here because all of it comes out. Okay, and this again becomes a part of the final equation. Again, we have a few standardized ones which the companies provides. Potassium normal, a low potassium one, a high bicarbonate one, but generally we use the standard bicarbonate with the standard potassium in patients. But yes, severely acidotic patients who are quite sick, you need a higher dose. So a bicarbonate higher, bicarbonate one can be used. Okay. Next part is the fluid removal, which is another component. Till now we are talking about solute removal. Now is the fluid removal part. So it's theoretically speaking, it's a bit easy. You just have to enter that this is the fluid removal I want. So the machine itself will throw out more fluid and replace it with a lesser amount of fluid, keeping the fluid balance in place. Okay. So what is the intake output you want over the next 24 hours? You have to balance it out. The machine will do the job for you, and ultimately again it will become a part of the effluent because that fluid is being wasted. So it will come into the calculation. Okay. Mostly we do not exceed 1.5 to 2 ml per kg per hour of ultrafiltration. Okay. Now, I think, I hope now it becomes clear that this is the final number that you want. That is the amount of effluent that is being thrown out of the machine. The components of this effluents have been the replacement fluid, this one, the fluid removed, that is the ultrafiltrate that you set in, and the dialysate that comes in. Okay. And this is where it is written, the total effluent dose. Okay. Depending on the modality, because this was an HDF that we discussed, the replacement fluid, dialysate fluid, and the net UF gives you the number. But if the dialysate is not being used, then only the replacement fluid and the UF gives you the number. So again, the calculation will be based on the modality that you use. Coming back to the original slide that we started off, this is your ultimate dose, that is effluent rate divided by the patient's body weight. Okay. We have to add a dilution factor, okay, because you know that the actual dose might be lesser than the number here, and this is a dilution factor that we use. Trials have said that there is no major advantage of using a high dose versus a low dose one, okay, and sorry, a high, yeah. So trials have said the recommended dose of 25 is good enough to remove the fluid, and a lower dose is good enough to maintain and give you the same mortality benefits as a higher dose. So there is no point in going to a higher dose one. And there are several studies that have said that increasing the rate of ultrafiltration might improve the survival, and CRT and dosings have an important implications in giving the expected outcomes that you want in your patients. Okay. So yeah. Another thing that is important is to monitor that whether the actual amount of fluid that and the dose that I'm doing is working or not. So there are 2 points in your monitoring, that is the delivered dose and the prescribed dose. This is what we have thought we would give, but you all know in the ICU many a times we interrupt the CRT. Sometimes there are downtime in the machine, the bags are being changed. Okay, we need to do a CT scan. So your actual dose might not be the one that you have thought in the morning, and you next morning you see for out of 24 hours only 10 hours. There was a 10 hours gap or the 6 hour gap. So the prescribed dose should be not less than 20% of the actual dose that of CRT that is being given, and we monitor it in the ratio of the prescribed, the delivered and the prescribed dose, and that's 80%. We measure the effluent urea nitrogen and compare it with the blood urea nitrogen. Again, it should be more than. For how much time the machine worked, at least 80% of your prescribed time the machine should be working and on flow. Coming to the last few slides now, filtration fraction is another thing that we calculate. It is calculated to make sure that your blood doesn't clot. Okay, that basically is how much is filtered out and how much is sent back to the patient. Generally, 20 to 30% of the plasma that goes in should be moved out, not more than that. And this is the complexities that we have to work with. We have to connect with it ECMOs, and we have newer machines. We have then upgraded machines which does a lot of this work, shows this you in the photo, and makes your life a bit easier. A bit about anticoagulants. Heparin we have been using, but this is what we have started using in increasing numbers in our ICUs with the regional citrate anticoagulation. We do need to work closely with it because any overdose can cause hypoglycemia and citrate toxicity, and this is where we add the citrate in the pre-replacement fluid, and we measure the calcium in the effluent to make sure that a dose, level of 0.25 to 0.5 of calcium is maintained in the patient, in the effluent, in the return line, and 1.1 to 1.3 in this line. So this is the summary of a CRT prescription. You set in the blood flow, you set in the dialysate flow, the pre-replacement, the post-replacement if required, or if you decide by you, the net fluid removal, and what is the composition. What is the composition of my fluids? Okay, either it is a standard one, if you are using anticoagulant, without citrate one. If the patient is highly acidotic, I'll use a high bicarbonate one. If the patient is highly hyperkalemic, I'll use a 0 or a low potassium one. Thank you for your time. Thank you.
Thank you, Dr. Manish. The question answer session will be in the last. Now I invite Dr. Kapil Dev Chabra, who is a senior consultant and HOD in Department of Critical Care Medicine, Maharaja Agrawal Hospital, New Delhi. And he'll be speaking on edema everywhere, but still hypovolemic, managing the volume paradox.
Hello, good morning everybody. And first of all, I thank organizing committee and chairpersons to invite me to discuss about this important topic of volume paradox, where the patient seems to be hypervolemic as well as he is hypovolemic. How to judge that, how to diagnose that, and what to do about it. So initially, as it sounds very contradictory that the patient is hypervolemic, and still we are saying that the patient could be intravascularly depleted and hypovolemic, and the patient might need fluids. So how does it go about it? So actually, this is a fluid maldistribution where one compartment of fluid is depleted, the other compartment is overloaded. To discuss about this, we have to go back to our basics, that 50 to 60% of the body's weight is consisted of fluids, and two-thirds of that fluid is actually into the intravascular compartment, which is separated from an extravascular compartment through a cell membrane, and sodium potassium pumps keep sodium out of cells, potassium inside the cells, and sodium remains an important electrolyte of extracellular fluids. So this extracellular fluid is further divided into two parts, intravascular and interstitial fluid. Interstitial component consisting of two-thirds of the total extracellular fluids, and one-third is 25% of the total extracellular fluids is in the intravascular compartment, and these two fluid states are separated by a tight endothelial junction, important role to keep the fluids segregated. And the fluid from interstitial compartment goes back to intravascular compartment through lymphatics. So what happens here is there are stalling forces which contain the fluid in different compartments, and intravascular fluid is maintained through a plasma oncotic pressure which keeps the fluid in the intravascular compartment. Then the hydrostatic pressure which tends to push the fluid out of intravascular compartment, and the capillary tight junctions which do not allow the larger molecules to move out of intravascular compartments. So the diseases which causes low albumin, low protein levels, the diseases which causes high hydrostatic pressure would tend to move the fluid out of intravascular space to the interstitium. And the most important one which we see in our day-to-day life in critical care in ICUs is capillary leak syndromes, where the capillary tight junction of capillary endothelium, they give way the proteinaceous fluid out of intravascular compartment, and that leads to interstitial edema. So the cytokine storms that lead to damage of endothelial cells lead to move the fluid out of the intravascular compartment, and it fills the interstitial compartment, but at the same time it leaves the intravascular compartment in the depletion. So that is the situation of fluid maldistribution, where interstitial fluid actually is in the higher amounts, the percentage of interstitial fluid has increased, but the intravascular fluid have decreased, so this maldistribution has to be corrected. At the same time, when depletion of intravascular fluid, there are activation of various systems including RAS system, AVP release, sympathetic system, which leads to further retention of sodium and water, and that could lead to increase in interstitial fluid, giving rise to edema. So these are the few causes. The most important ones in our ICU would be sepsis and SIRS, which is caused by pancreatitis, trauma, burns, tropical illness, dengue patients we are seeing these days. All these diseases, they lead to capillary leak and this fluid maldistribution, where the patient looks hypervolemic but actually intravascularly depleted. So once we understand this part of fluid maldistribution and we understand the patient is having interstitial edema, at the same time intravascularly depleted. So how do we detect clinically? How do we approach this patient to detect first and then to treat? So first is to check the intravascular depletions. We have to we have to assess this whole circulatory system of arterial perfusion, the perfusion at the cellular level, the venous part, the whole system. We have to understand whether the patient is intravascularly depleted or not. But at the same time, there are certain measures by which we can detect the interstitial edema, the interstitial fluid overload. So to detect the intravascular hypovolemia, we have all these parameters like static hemodynamic monitoring, dynamic hemodynamic monitoring, and we can do fluid challenge test to assess whether the patient is intravascular depleted or not. So we have already read about this CVP and pulmonary artery occlusion pressure, which these days are less used because they are the static hemodynamic monitoring system. In the dynamic hemodynamic monitoring system, we have intravascular IVC diameter, which in positive pressure ventilation, we see the distensibility of IVC diameter. So if it is more than 18%, we believe that the patient would be fluid responsive. And on positive pressure ventilation, then PPV and SVV, the pulse pressure variation, if the patient is on positive pressure ventilation, the patient is paralyzed, patient is getting good tidal volume, the heart-lung interaction may lead to increase in PPV if the patient is fluid depleted. The tidal volume challenge test, another modality to detect intravascular depletion and expiratory occlusion pressure. So whenever there is an increase in intrathoracic pressure, the cardiac output decreases, and that is how you further check the PPV, and if there is any change in PPV, the tidal volume challenge test becomes positive. And expiratory occlusion pressure, you give endo-expiratory occlusion to the airways, that leads to increase in cardiac output by 5%, that shows that the patient is intravascular depleted. So fluid challenge test, as we know, we give little amount of fluid. In this case, it would not be an acceptable thing. The patient is already showing signs of hypovolemia. If we do fluid challenge test, the main drawback of this test is that this is an irreversible phenomena. Once you have given the fluid, then you will be able to know whether the patient is fluid responsive or not, but at the same time that fluid has already gone to the patient. So another aspect of that is that we can move on to passive leg raising test, which causes auto transfusion of about 300 ml of fluid, and look for cardiac output changes after passive leg raising. So these are the modalities which can be used to detect whether the patient is fluid responsive. Which one would be the best? I would say dynamic parameters are better, and they give a real picture of fluid responsiveness of a patient. Now, coming on to the interstitial edema, which is another part of our talk, that how do we detect the patient is having interstitial edema? So one is by externally looking at the pedal edema or the sacral edema of the patient. Sorry. So the other aspects by which we can understand the patient is having third space fluid would be ascites, intestinal edema by way of measuring intra-abdominal pressure, then pleural effusion, interstitial edema, pulmonary edema, ARDS, lung ultrasound and extravascular lung water can help us detecting these extra interstitial fluid. Then edema in other organs. The indirect parameters is by measuring IVC. If diameter is more than 2 centimeter, then Vexus protocol can help us detecting intravascular overhydration and interstitial edema. So one thing I would like to say, if we are looking at the Frank-Starling curve and we are basically relying on IVC diameter or Vexus protocol, so that could be misleading, because IVC diameter, even if it is at the lower end, because of capillary leak process and because of hypoalbuminemia also playing a role in that, the patient could have additional interstitial edema despite low IVC. So once we conclude that the patient is having interstitial edema and the patient is hypovolemic or fluid responsive, should we start treatment for this patient? Should we start giving fluid to this patient? The answer is no. Just because a patient can increase his cardiac output by giving fluids doesn't mean that we should start giving fluids. The most important thing here is we have to assess whether the patient is showing signs of tissue hypoperfusion or not. So the signs of tissue hypoperfusion in the form of macrohemodynamics and microhemodynamics. So tachycardia, hypotension or organ dysfunction, which probably is due to hypoperfusion, can be taken as a tissue hypoperfusion. The laboratory parameters which very commonly we use in tropical illness, rising hematocrit we use in dengue shock syndrome, increase in blood urea creatinine and blood urea creatinine ratio, and increased uric acid. So the other signs of peripheral tissue perfusion, hypoperfusion could be cold extremities, skin mottling, poor CRT more than 3 seconds, rising lactate, decrease in SCVO2, increase in CO2 gap, and decrease in tissue oxygenation saturation. So all these parameters, once combined with the fluid responsiveness test and the patient is having peripheral hypervolemic state, then we decide about giving treatment to such patients. Now we'll move on to what kind of treatment we are planning for such patients. So as we know, the patient is intravascular depleted, so definitely fluid will be the most important treatment part of capillary leak syndrome. At the same time, you have to monitor it closely and you have to treat the underlying cause so that this capillary syndrome should shut down and the patient should reach in a state of euvolemia. So the question in front of us would be how much fluid we should give, whether we should be aggressive or restrictive in giving fluids, when the vasopressor should be started, we should start it as a last resort or we should start it as an adjunctive in the initial stage or at early stage, or which fluid is to be given, whether it is the crystalloids or colloids, and if crystalloids, which crystalloids. So these are the fluids you have already discussed in the previous chapter. So crystallite fluids, if we give, it will go into the interstitial fluid as well as intravascular compartments equally. So at some stage you have to add vasopressors, maybe at early stage or at later stage. But at the same time, we have to understand that whenever we are giving crystalloid fluid to the patient, there is always a risk of increasing interstitial edema here. So we will be improving the intravascular hydration of the patient, but at the same time, the patient may land up in increased interstitial edema leading on to pulmonary edema and increased intra-abdominal pressure. So ideally, if we give colloid, it should be expanding the intravascular compartment only, and definitely vasopressors would be given at some stage, but it will cause less interstitial edema. So this is the most majorly a physiological concept, but does it practically can be implemented? We'll see. So in guidelines of septic shock, it has been advised that the patient should be. The crystalloids have already won this battle between crystalloids and colloids. So albumin should be given only if the patient is still requiring fluid after giving a lot of crystalloids, and the patient should be managed with dynamic hemodynamic monitoring, and tissue perfusion in the form of lactate clearance or CRT should be checked simultaneously. Now to understand whether we should give fluid in good amount or it should be a restrictive, we had this classic trial and Clover trial which were done in Europe and USA, and in about 1600 patients they have concluded that restrictive fluid therapy is as good as liberal fluid therapy or aggressive fluid therapy, and there is no mortality difference between the two, and simultaneously there is no difference in the serious side effects also between the two groups. So earlier in 2001, when we started our training in critical care, we were being told that you have to give early aggressive resuscitation fluid based on EGTT study by reverse, and later on in 2014 and 15, we understood that it is not necessary to go for early aggressive fluid. It is important to give timely fluid, but it may not be an aggressive fluid. So SOAP study also had a subgroup analysis where positive fluid balance increased mortality. FACT trial also showed that conservative fluid therapy can decrease ventilatory days without increasing shock. So this we have already discussed in the previous presentations, which fluid is to be given. Colloid have never won the battle, so it's always crystalloids, but still it's a debatable whether balanced crystalloid should be used or NS should be used, and in colloids albumin is the safest option. So can we use albumin in the initial phase of capillary leak? The answer is no, we should not be using initially, because there are chances of leaking of albumin through the capillaries, because it's always protein rich fluid which is losing from the capillary leak. So albumin plus loop diuretic also should not be given in the initial phase of capillary leak. So fluid resuscitation should be monitored by using dynamic parameters and tissue perfusion parameters. Start vasopressors early. Do not be very heavy on the crystalloids. Do not increase tissue edema simultaneously. So third spacing should be minimized as much as possible. In trauma also, the most important thing I want to highlight is that in the previous ATLS guidelines, it was given as to resuscitate the patient, 1 liter of crystalloid should be given immediately. But in the latest guidelines, they have also approached a restrictive approach of giving IV fluids of 250 ml to 500 ml of crystalloids. So this is a waterfall trial which was published in NAGM in 2022, where moderate amount of fluid in pancreatitis is found to be better than fully liberal aggressive IV fluid resuscitation in acute severe pancreatitis. So there was no difference in incidence of a person landing up into moderate or severe pancreatitis, but at the same time, the aggressive fluid group had higher incidences of fluid overload. So the guidelines are now changing on to using moderate amount of fluid, 10 ml per kg followed by 1.5 ml per kg in first 24 to 48 hours, so as to avoid excessive interstitial edema. So we have to understand that we have to give fluids, we have to maintain the hydration of the patient so as to have a good and benefit in mortality and morbidity, but at the same time we should not be giving so much of excessive fluid so as to lead to such situation where we are landing up into interstitial edema. So the most important thing is that if perfusion is adequate, then you do not use fluid. The perfusion is not adequate, patient is fluid responsive, and the lung ultrasound shows there is no interstitial edema in the lungs, only then you give fluids, and that too restrictive approach. Do not forget to treat underlying cause so that we can come out of this situation as early as possible. Reabsorptive phase would be coming after stabilization, when the fluid will move from interstitial compartment to the intravascular compartment. That is the time to evacuate the patient, to decongest the patient at that time. So the take home message is the capillary leak syndrome is an important entity which we see in day-to-day practice, and the capillary leak phase, you give early fluid, but be restrictive on the fluid. Do not be very aggressive in the fluid management, and continuously monitor the dynamic parameters of hemodynamics, and do not overload the patient. Early initiation of vasopressors would be the key. More and more guidelines are recommending that. Also take care of definitive cause treatment of the patient, and be careful in the reabsorptive phase when the fluid will be coming back to the intravascular compartment. That is the time you should be evacuating you should be decongesting the patient. Thank you very much.
Thank you, Dr. Kapil, for very elaborative this discussion on when to give fluid and when to stop. It is very much important for the newer generation to know, do not give liberal fluids. You have to restrict according to the patient.
Yes, and these days more and more guidelines, more and more studies, they are like in our training times, we were being told that you give aggressive amount of fluids. Do not bother about interstitial edema or fluid overload. That will subside once the capillary leak is settled. But now the evidence is showing more and more that you should be very restrictive on the fluid. You just give enough fluid to maintain the hypoperfusion, tissue perfusion of the patient.
Yes, true. May I request all the speakers to be on stage for the question and answer sessions, please? Dr. Aparna.
So let me start. Being a nephrologist, all the three speeches were concerned with me. So I'll be talking to Dr. Aparna. I'll be just asking her take on 3 or 4 clinical situation where we can use a balanced salt solution or not. So first is, as all nephrologists are worried of contrast-induced AKI, and we have many therapies like NAC was there, then it was a sodium bicarb therapy, and so on and so forth. Now the only thing which is recommended is hydration, right? So there will be 4 situations I am telling you, then you give me your take on that. The first is, what is your take on giving balanced salt solution in patient whom we are fearing of contrast-induced AKI? The second is, what is the take on patients who are having a surgical surgery intervention, and at the time when can we give a balanced salt solution? Where we require, the third situation is hypovolemic patient where you require more of fluids. Not going to the interstitium, but still you require more fluids. So can we give balanced salt solution in that? And finally, in those patients where we want to prepare an antibiotic infusion. So in all the 4 situations, what is the take of balanced salt solution in that respect?
So for the first question, in terms of hydration for prevention of contrast-induced AKI, the first thing to understand is that most of the studies have shown that it's larger volumes of versus balanced salt which are actually causing the hyperchloremic metabolic acidosis. So we really need to assess. So let us say a patient comes with acute abdomen and is very dehydrated because the patient is also having nausea, vomiting, and is in shock. This patient is already quite dehydrated and is going to require a larger amount for resuscitating at time 0. In this patient, I would still prefer to go for a balanced crystalloid. But if I look at another patient who's, for me, in the ICU is a routine, otherwise, having some other problem in the background, and I'm fairly certain that the patient is otherwise volume replete, it is okay to use normal saline or balanced crystalloid, anything. We also need to take into account that it is the hyperchloremic metabolic acidosis which is also being proposed as a mechanism which leads to AKI. So I would also like to have a look at the chloride levels at the time of initiating this fluid administration before deciding which fluid to choose. As long as I'm not giving very huge volumes, I'm okay with both fluids. This is the answer to the first question. The second question, surgical patient you mentioned. So surgical patient.
Are there any studies in all the 4 situations where they have compared normal saline with balanced salt solution or ringer lactate with balanced salt solution?
So for contrast-induced AKI, I'm not specifically aware of any landmark trials. I'm sure there must be something small, but just looking at how it works, I think this is how it should be. I'm not aware if there are any particular studies. In terms of surgical patients, there is now plenty of evidence in all sorts of surgery, whether it is GI surgery, pediatric surgeries, liver transplant, perioperative, liver transplant definitely, and perioperative, even renal transplant patients, that when compared to normal saline, balanced crystalloids do offer an advantage. And the recent surgical guidelines also recommend balanced crystalloids as the first choice of fluids for resuscitation as well as maintenance fluid for all sorts of perioperative patients. So that is what is very strongly recommended in most surgical guidelines currently.
Usually surgeons gives more of ringer lactate rather than normal saline.
So that is balanced crystalloid, right?
You can say so, but what you have proposed is a balanced salt solution which is having a different proposition or composition as compared to a ringer lactate.
So far there is no evidence comparing one balanced crystalloid to another. So surgeons, yes, definitely use a lot of ringer lactate. I agree to that, but do we have very strong studies to recommend one balanced crystalloid over another for any kind of situation? No, not as yet. There are some small caveats. For example, liver transplant patient, avoid a lactate because you're going to have an anhepatic phase, so avoid lactates, and especially these patients require huge volumes to be administered during the surgery. But apart from that, almost all studies have like an equivocal result on which balanced crystalloid to choose. So ringer lactate is also good enough, and it, I think, kind of depends on a lot on familiarity and availability also. So any balanced crystalloid for a perioperative patient should be fine. I kind of forgot your third question.
Antibiotics.
There's a huge problem about drug precipitation. For example, most antibiotics would precipitate with ringer lactate. So when it comes to drug reconstitution, it is still recommended to dilute in normal saline or dextrose. And if you have a doubt, you can read the package insert or the manufacturer's recommendation. But if you go through all FDA prescribing information, most drugs are recommended to be diluted in either normal saline or dextrose. So for drug dilution, reconstitution, normal saline, distilled water, or whatever is recommended by the manufacturer would what be used.
Thank you. I have one question. It's for Dr. Kapil. We have been seeing a lot of dengue patients with evidence of plasma leakage, and you mentioned that albumin should be used in a very tricky way. So is it contraindicated, or it has to be used particularly in a refractory shock? Another important practical point is that there was an article in NEGM, ringer lactate versus normal saline in capillary leak syndrome. So what is the current guideline?
So, talking about albumin, so once the patient has a capillary leak syndrome, there is always a risk of leaking of albumin-rich fluid. So the patients who of dengue shock syndrome who land up in ARDS, they have a protein-rich fluid extravasating through the lungs, leading on to ARDS, and they have our preference and guidelines do recommend crystalloids as the first choice of fluid, and albumin. See, crystalloids you can, as it is equally distributed in the intravascular and interstitial compartment. 75% of it goes to the interstitial compartment. So it is not that crystalloid would stay all into the intravascular compartment. But at the same time, initial fluid resuscitation to be done by crystalloids fluids, and if you believe that you have given enough amount of crystalloid fluid and the patient still requiring more amount of fluid, only then there is a role of albumin.
And that too 5% albumin?
That too 5% albumin, yeah. So 5% albumin is not readily available, I would say. So we do have a choice of 20% albumin only, but yes, given a choice for fluid resuscitation purposes, 5% would be the better.
So one last question from Dr. Munish, if House doesn't have any question. CRRT came into picture when Dr. Ravindra Mehta started the procedure way back in 2000s when we were in the training. And over 10 years, it was like every patient who is in critical care should need CRRT, and KDIGO also published a guideline in 2012. But what is the current status as on today? I say post-COVID what we say, because we are now feeded up with more of information. When you compare CRRT with SLED, what is the outcome? Is there any trial which has seen both the patient group and given us something where we say that SLED is better or CRRT is better, because we are an economically driven country? So your take on that?
So my take would definitely is in line with what you mentioned, because we have a wide diversity in medical availability of machines and expertise. So obviously we can't say that everyone should get a CRT done. Okay, so it's not possible in the country as diverse as us. Data has been building up over the past years. It's still a novel modality in this part of the world, and definitely managing patients on CRT, personally that I've been using it, is definitely easier, because I can micromanage the fluid, I can micromanage the solutes, which becomes a bit difficult when I do a SLED. Does it cause a mortality benefit? Yes, probably. Okay, but it's very difficult. We cannot design studies at this point of time which will give us a clear-cut answer that yes, CRT will be is maximally life-saving and SLED is not. We do have advantages of SLED in some cases where you need a rapid correction of acidosis and all, of potassium and all. SLED might be preferred. So just to sum up here, I would say my personal take would be yes, I would personally prefer a CRT one, but if you don't have a CRT, that doesn't mean that we cannot do anything else. SLED can give a partially and almost as good as a result, unless we are able to obviously manage it. We can have hybrid therapies. If you remember my second slide, they have hybrid therapies where you have an extended SLED, you run it for 12 hours and maybe longer if the situation rises, or some hybrid modalities can be done, because CRT is costly, no doubt.
Just to complete your, there was a paper published in Medicine 2021 where they have retrospectively analyzed 11 trials from US, Germany, Italy, China, India, every part of the world. And what they found was that the SLAD and CRRT were same in average length of stay, hospital mortality, renal recovery. Every complications were practically the same in both. So in our country, what I think is, when we are sitting in an economical driven country, I think SLAD would be a better option, less cumbersome, less technical technician.
Definitely depends on what you
use.
have actually. You
So
have to
that
work
would be
with
a
what you
better
have.
option. So any question from the audience? Yeah. One of the person who has worked with Dr. Ravindra Mehta, so he can tell us more about CRRT. Dr. Piyush Mathur.
I think this controversy of SLED versus CRRT is always discussed in most of the meetings. Basically, these are complementary to each other. I agree that whatever studies, meta-analysis has been done, there is no difference between CRRT and SLED. But yes, definitely two conditions: when the patient is unstable with hemodynamics, unstable hemodynamics and raised ICP, these are the two conditions where CRRT definitely scores over SLED. Studies have proven this. Also, one of the recent studies has shown some mortality benefit of CRRT over SLED, which was not there in the earlier studies. So I strongly suggest to use CRRT in critically ill patients with unstable hemodynamics, and definitely in patients with liver dysfunction with raised ICP, any other condition where whenever there is raised ICP. So CRRT should be used. That is also the recommendation from KDIGO also, that it scores over SLED.
Agreed.
Thank you. Thank you for a good insight, and we close this session. And thank you, speakers.
Thank you,
for
sir.
giving us the
Thank
time.
you.
I'd like to request our respected faculty and chairpersons to visit the felicitation counter. Our EC team is eagerly waiting for you over there. Thank you.
Now I would like to invite our esteemed chairpersons for case discussion of fluid management in dialysis dependent ICU patient.
Dr. Munish Chauhan, Additional Director, Critical Care Medicine at Fortis Memorial Research Institute, Gurgaon.
Dr. N.K. Joshi sir, Assistant Professor, Retired Senior Consultant, Critical Care Medicine from Government of Rajasthan.
Dr. Piyush Mathur, Senior Consultant Nephrologist, Santokba Durlabji Memorial Hospital, Jaipur.
Dr. Pooja Vadva ma'am, Clinical Director and Head, Department of Critical Care Medicine, Moringa Asia Hospital, Gurgaon and Faridabad.
Dr. Amit Mehta sir, Consultant Intensivist, Apex Group of Hospital, Jaipur.
And our presenter, Dr. Apul Mathur sir, Associate Consultant Department Critical Care Medicine, Apex Hospital, Jaipur.
Good morning, respected seniors and dear colleagues. So after that great sessions, we will discuss our case capsule, and our case capsule topic is fluid management in dialysis dependent ICU patients. So we will start with the scenario. A 62 years old male patient of weight approximate 55 kgs with relevant past history of type 2 diabetes mellitus since last 15 years, and hypertension of 10 years with this CAD status post PTCA 2 years back, with a CKD SRD history on maintenance hemodialysis thrice weekly with AV fistula since last 9 months. Was admitted in ICU under nephrology team with the presenting complaints of high-grade fever 101.4 with chills and malaise for 3 days, shortness of breath, orthopnea, and decreased urine output. He is still passing 150 ml per day of urine otherwise, and progressive confusion and slurring of his speech since morning. Altered sensorium, tachypnea, and hypotension was there at presentation in hospital. The history of last hemodialysis session was 36 hours prior to admission. So the initial vital parameters, airway, patent, but the gargling sound was, secretions were there. Breathing, respiratory rate was 34 per minute. SpO2 of 88% on O2 mask, 8 liters per minute. Bilateral crepts, accessory muscle use was there. Heart rate of 138 beats per minute and MAP of 52. Blood pressure systolic 78, diastolic 42. And capillary refill time was 5 to 6 seconds, closed extremities. Temperature 39.1. Urine output around 10 ml in last 4 hours. He is otherwise anuric at baseline between hemodialysis sessions. So initial labs, ABG on 8 liters, pH 7.24 with the PaCO2 of 31, PaO2 of 66, bicarb 13, lactate 5.2, sodium of 132, potassium 5.7, chloride 98, calcium of 7.8, potassium, phosphorus of 5.9. CBC, WBC's counts 22.5 with a 92% of neutrophils, and hemoglobin is 9.2, platelets 180, BUN is 98, creatinine was 9.6, baseline creatinine was 8 to 9, CRP raised 212, and procalcitonin is 24. Blood ketones negative, ECG showing sinus tachycardia. So here is the first X-ray on admission, showing bilateral infiltrates, pulmonary edema like findings. So here our provisional diagnosis is this: acute hypoxemic respiratory failure with shock, and it may be septic or cardiogenic with pulmonary edema, hyperkalemia, and severe metabolic acidosis with known history of diabetes, hypertension, CAD, PTCA, and ESRD on dialysis dependence. So here, what we have to do next. So our first questions from respected Dr. Munish Chauhan sir. Sir, what to do now to give fluids or to give vasopressor in this patients or both, and the MAC targets in this patient, please sir.
So I think this is an age-old discussion that always goes as a nephrologist on my side. I'm an intensivist. Yes, though you've been kind enough to give us a lot of data in telling that the fluid is quite excess in this patient, but one thing that I'm very clear about is, yes, we need to give, definitely, no questions asked, because now the recent guideline data has shown that you don't wait. Earlier we used to be told that first give fluids, then give vasopressors, which is not true now in the present time. We give vasopressors, noradrenaline preferably, we increase the MAP targets usually are 65. There's another school of thought that in the elderlies on chronic hypertensives, a MAP higher than 65 might help. Bit of a discrepancy on the data, but 65 at least minimum has been found to have an equal mortality benefit. Fluids, I would need more information, frankly speaking. I would need to know what is the echo, what are the focus and the vexus findings and all
Slides.
in the little slide. So I won't be that gung-ho about giving fluids at this point of time, frankly.
Okay, sir. And sir, MAP targets in this CKD patients?
So again, as I said, 65 is what most of the guidelines say.
Yes.
Some say, okay, you might go to 70. A higher MAP has not been shown to be that advantageous.
Okay.
So I would still work around with 65, max 70 or so. 65 to 70. These are hypertensive also.
Thank you so much, sir. So moving toward next questions from Dr. Amit Mehta, sir. Sir, please. How do assess volume status of such patient at this time? Sir, mic not working, sir.
The fluid assessment in ESRD patient is always a tricky. So like at this point of time, we'll do the clinical assessment. So clinical assessment starting with the symptoms, what are the symptoms of the patient, and then sign. And signs we need to check head to toe examination. Like starting from the, like look at the eyes, look at the tongues, look at the JVP, whether JVP is raised or not. Then you do the auscultation. like whether by any crepitations are present or not. Then look for the peripheral edema. A peripheral edema is present or not. Then skin temperature, and look for the capillary refill time, whether it is raised or not. And there are other investigations also like ultrasound and 2D echo and some investigations like pro-BNP, you can do it. But for pertaining to this case, he is having orthopnea,
Yes.
and on auscultation, bilateral crepitations are present. And he is in the capillary refill time is raised.
Yes.
So he is fluid overload but in the shock state.
Yes. Thank you, sir. So further investigations in 2D echo, there is a moderate systolic LV dysfunction with an LVEF of 35 to 40 degrees. No pericardial effusion, diastolic dysfunction is there. Ultrasounds, no intra-abdominal source of infections, and bilateral chronic kidney disease with small hyperechoic kidneys, minimal bilateral effusions. Additional labs, we have TROPI 0.4 and an anti-pro-BNP of 2000. So moving towards next questions from Dr. N.K. Joshi, sir. Sir, is there any way to assess fluid responsiveness in present situation in these patients?
Yes, we have many tests which can be used in for fluid responsiveness, but here these tests are very tricky because
Yes,
patient is spontaneously breathing.
Yes, sir.
Patient is not on ventilator. Majority of the tests they work well when patient is ventilated, sedated, and paralyzed.
Yes.
Second thing, patient is CKD post PTCA and EF is around perhaps 40.
Yes,
So if you give fluid, there is chance of fluid overload. So we have to choose test which works well in spontaneous breathing, as well as if there there is no need of fluid infusion. So there are PLR can be used.
Yes.
In PLR, what we do, we just raise the leg,
Yes, sir.
and but in for PLR there should be specific beds needed. It is not just like that we will raise the leg.
Legs.
We have
Yes,
to
sir.
move whole bed in propped up position and lower down the head. So specific beds needed. Second, for PLR we have to monitor accurately cardiac output and stroke volume. So we will need some method of monitoring stroke volume or cardiac output. For that we have to put at least arterial line, or you can go with echo by measuring VTI.
Yes.
So PLR is ideal. Second test that is evolving is end expiratory occlusion test,
Yes,
which can be used in spontaneously breathing patient, and if patient can sustain apnea for 10 to 15 seconds. So these two tests can be used, and if you are using NIV, then change in ETO2 can be also used in this patient. If there is more than change is more than 2, then after PLR, then we can say patient may be fluid responsive.
Okay, sir. Thank you, sir. So moving to our next questions, Dr. Pooja Wadhwa, ma'am. Is there any harm of fluid therapy here after this?
Since the patient is already in fluid overload,
Yes, ma'am.
already has a low EF, 35 to 40%, with high oxygen requirements, already in fluid, in pulmonary edema, so
Yes, ma'am.
I'll be very skeptical about giving him any fluids. I would like to maintain his blood pressure with
Vasopressor.
noradrenaline
Yes.
infusion only, if I can maintain a MAP. But depending upon the response, then I will decide whether I can give him some small amount of fluid or not.
Okay. So case is continued. So noradrenaline infusion was started at 0.15 micrograms per kg per minute with the target of MAP of more than 65. So the blood pressures are still worsening, MAP 55, and heart rate is almost same, 135 beats per minute. 90, so oxygenation is slightly improved with increased in oxygen requirements and with NIV support. So worsening of shock and worsening of O2 requirements. Initial management we have obtained the cultures before antibiotics, and we have empirically started antibiotics here. And simultaneously NIV, non-invasive ventilation was also started in view of low PF ratio, and SLED was started in view of fluid overload, pulmonary edema and cardiogenic shock. So cases continue despite of initiation of RRT of around 35 to 40 minutes. Patient condition deteriorated with worsening respiratory and failure and hypotension. SLED was withheld. Patient was intubated and taken on mechanical ventilator supports. Noradrenaline dose was increased to 0.25 micrograms per kg per minute. Here the repeat ABG was done with a pH of 7.20, PaCO2 of 38, PaO2 of 55 and bicarbonate 11 and lactates 4.4. So PaO2 is worsening, bicarb is worsening, pH is also worsening here. Initial ventilator settings in are lung protective ventilation, and the in post intubation X-ray was here with worsening bilateral chest infiltrates, and air bronchograms are seen here, consolidations. So central lines and arterial lines were placed, endotracheal aspirates were sent for cultures, sensitivity and gram stain. Here HRCT chest could not be performed as patient is not shiftable due to hemodynamic and respiratory instability. So we have done some dynamic assessments. The PLR was done, which after the PPV was measured, there is no significant fall in the PPV, so PLR is negative. The lung ultrasound was done, mostly showing the pattern of ARDS and pneumonia with a minimal to mild effusions, bilateral. Lung sliding was preserved. Here IVC is distended, no respiratory variations was there. Here a role of PICO monitoring is also in this patient, although we have not done, but it can show us the extravascular lung water index also for quantifying the pulmonary edema and to differentiate between fluid overload or ARDS severity. So next the proning was done with a low PF, and moving to our next question. So from Dr. Piyush Mathur sir. Sir, if needed, what type of fluid should be used in this patient, normal saline or balanced crystalline in this situation, sir?
I think of late there has been quite a lot discussion on balanced crystalloids versus saline. So this is mostly because of the closer composition to the plasma, as well as the risk of hyperchloremic metabolic acidosis with saline. But this happens when we are using large volumes of normal saline.
Yes.
Okay. Moreover, the study which has been done to compare these two has many shortcomings in terms of many bias in terms of patient selection, volume of use, single center study. So if you are talking about this particular patient, in this patient when the chloride is 98, patient is having high anion gap metabolic acidosis,
Yes.
and when we are not using large volume of fluid in this patient, either of these can be used. However, some data is there, some guidelines also recommend these days to use balanced crystalloids. They prefer over saline, the reasons which I already mentioned. So in this patient, either of these two can be used because we are not giving much fluid in this patient.
Okay, thank you, sir. So here is the diagnosis: bilateral pneumonia, severe ARDS, sepsis, shock, septic shock, hyperkalemia, and the known case of CKD on maintenance dialysis with the CAD and moderate LV dysfunction, hypertension, diabetes. So moving to our next questions from Dr. Amit Mehta, sir. Sir, what tools should guide for fluid therapy in an ESRD patient? Some modern tools.
Like in ESRD patient, fluid precision is important.
Yes.
Rather than like fluid avoidance or fluid overload. So there are like multiple tests was as already discussed. Like one is POCUS, ultrasound lung. So lung ultrasound you can do, you can check for the B lines for
Okay,
pulmonary congestions.
Okay,
You can do the lung ultrasound score, and then coming to the 2D echo. So in echo you just measure the systolic dysfunction, then diastolic dysfunction,
Yes.
E by E dash or filling pressures you can check, and you can check the baseline VTI. And like IVC you can check the diameter of the IVC and whether any respiratory variations are present or not. And then the newer modality like VEXIS you can do. So in VEXIS, like this is a Doppler-based assessment to check for the congestions. But I think VEXIS needs more validation in these patients. And as in the dynamic test, what you have done, like PLR test, you have done PLR with VTI.
Yes,
So in PLR, in pertaining to this case, like PLR is less than 10% with VTI.
Yes, sir.
So I think there is no need for giving fluid at present in this case. You just need to escalate the vasopressor support.
Thank you, sir. So case was continued after 4 hours of proning session. Again, worsening of hypotension was there. Noradrenaline infusion 0.5 micrograms per kg per minute with a ABG of 7.12 pH, PaCO2 of 42, PaO2 of 90, bicarbonate 12, lactates 5.5, base deficit of -13, sodium 139, potassium 5.9, and chloride 111. After 4 hours of proning, the improvement in SpO2 was there, 82 to 94%. There is improvement in PF ratio from 80 to 130. And the drops in there in MAP from 65 to 58, increase in the noradrenaline infusions, lactates increase, urine output as usual nil, severe metabolic acidosis with worsening shock. So moving to our next questions from Dr. Munish Chauhan sir. Role of SBC sir in worsening of metabolic acidosis in this patient sir?
Now, that is a bit tricky one because, over the past many years, we have been banking upon soda bicarb. Initially, it was supposed to be a lifesaver that, okay, it seems to be correcting everything. But as we've been progressing with more information, with more trials, we have started, decreasing usage of soda bicarb quite a lot. If I pertain to this patient, it might qualify for use of soda bicarb because the pH is below that magic number of 7.15. And there's hemodynamic instability. So maybe yes, low dose can be tried because if we are quite sure that the patient is hypertensive because of acidosis, already the EF is low and the diseased heart is generally doesn't respond well to acidosis, and even the patient is on dialysis, and you can sort of use it as a bridge, but not as something which is dependent totally on that.
Okay.
The flip side, definitely it can increase the carbon dioxide, theoretically speaking, but here the carbon dioxide. Okay, so I would, yes, I would not bank upon too much, but as a bridge for temporizing measure, yes, can think.
Okay, thank you, sir. So we have given a bolus dose of sodium bicarbonate infusion is here. So moving to our next questions. So from Dr. N.K. Joshi, sir. Despite improved oxygenation and hemodynamics worsens, what could be the reason of post-prone shock worsening, sir? Here, please.
Okay, so in this case, we have done proning. So proning itself may lead to hypotension. Because when we prone the patient, there is increase in intrathoracic pressure. That may lead reduced venous return, as well as there is increase in intrathoracic pressure. That may also reduce venous return. So there may be hypotension due to proning itself. But before that, we have to rule out whether our arterial line is, because proning may lead to dislodgement of arterial line, or arterial line is working properly, or central line is not occluded, maybe our vasopressor have not going.
Yes,
and
sir.
second, we have to check our patency of the airway and tubing. If there is any occlusion, then intrathoracic pressure may rise. That may also lead to your hypotension. Second, as patient is showing that fluid overload as well as PLC raised, perhaps pneumonia. So pneumonia itself have perhaps worsened. That may also lead to further worsening of the
hypotension.
Yeah.
So case was continued. Vasopressin was added to noradrenaline. Here the MAP slightly increased to 64 with noradrenaline and vasopressin. Simultaneously, we have done ABG and VBGs to check the delta PCO2 gaps and SVO2. And this shows an adequate flow, but high O2 restrictions consistent with septic shock rather than purely hypoperfusive cardiogenic shock. So moving towards the next questions from Dr. Piyush Mathur, sir. Sir, when should RRT be initiated in a dialysis-dependent patient with shock, and which modality, sir?
So in this patient who is already dialysis dependent, I agree with Manish sir that there is no role for soda bicarb because this patient is already dialysis dependent. We have a vascular access, and we can state moreover 36 hours have already been passed, so we can directly go with dialysis in this patient. But one thing which I would like to mention here is in these type of patients, please don't use the AV fistula because patient is already in shock and we may injure the AV fistula. So rather than using fistula, make a new, temporary access, use a temporary access for these patients, right? Yeah. So since this patient is already in shock, patient is having bad heart, bad lungs, with bad hemodynamics, preferred modality is of course continuous renal replacement therapy rather than going for SLAD or HD. So I will prefer, as well as the recommendation from KDIGO is also to use CRRT as compared to SLAD in such subsets of patients who are unstable with hemodynamics. Yeah. So CRRT should be preferred in this patient.
Okay. Thank you, sir. So this patient meets urgent RT indications for respiratory refractory acidosis in urea hyperkalemia ARDS. So CRRT was initiated and CRRT was started with initially no UF. So my next question from Dr. Pooja Vadva ma'am. Is albumin indicated during RRT in resuscitation in this case?
So this patient already has a CKD on thrice weekly dialysis.
Yes,
so I suspect he would anyways be low on albumin because he might be losing a lot of protein during dialysis. And since I cannot give him enough of fluid, not much of fluid, so plus a hypoalbumic state will warrant for albumin transfusion. So I might give him, depending upon the hemodynamics, along with the renal replacement therapy.
So if the albumin is critically low, in that case. Okay, ma'am. So these are the ABG trends. First three ABGs we have already discussed. After 4 hours of CRRT, the pH is improving, lactates are downtrending, FiO2 is decreasing, and MAP is improving. So after this, the supine position was done. Almost 6 hours of proning was completed, and after 12 hours of CRRT, the pH is still improving sides. Lactates improving, noradrenaline requirement is decreasing, vasopressin was already stopped. Oxygenation is maintained in supine after 4 hours, so PF ratio is around 180, so no further proning was done. X-ray in supine. So there are slight improving in X-ray in supine, but with CP angle blunting, the pleural effusions were there, somewhat volume overload was there. No further proning was done, noradrenaline was tapered off, sedation off, and the patient is neurologically intact. Here chest ultrasound was done, bilateral moderate pleural effusion towards right side is more than left, and underlying consolidations. So moving towards next questions from Dr. Piyush Mathur sir. Sir, how should ultrafiltration be targets in this shock phase or improving shock phase?
See, when we are starting any modality, any form of RRT, particularly in this case CRRT, we should first fix our goals. What is the indication why we are starting CRRT in this patient? So in this patient, our primary goal is not to remove the ultra volume. It is first to stabilize the patient. So once the patient gets stabilized, like in your ABGs, that has shown that there is improvement in the acid-base status, there is improvement in the electrolyte, there is improvement in the MAP. Now that is the time when we can always start ultrafiltration, not at the outset when we are starting. We should wait for some time, 3 or 4 hours, let the patient get stabilized, and then we can always start the ultrafiltration, particularly in this case, because that is not going to change anything starting ultrafiltration at the outset. We can wait. And moreover, ultrafiltration which we are doing in CRRT is at a very low speed. If you will do at least 3 ml per minute of ultrafiltration, that can remove approximately 4 liters of fluid in next 24 hours. So you have plenty of time to do ultrafiltration. So I don't think so that we should start ultrafiltration immediately in this patient. wait for couple of hours, wait for 4 to 5 hours. Once the parameters shows improvement, we can always start the ultrafiltration with 1 to 2 ml per minute, and then increase to 2 to 4 or 5 ml per minute depending upon the patient hemodynamics and the required goal, required ultrafiltration, how much we need.
Okay, sir. Thank you, sir. So here is the summary of improvements. We have discussed already the cultures of endotracheal aspirate growing pseudomonas aeruginosa sensitive patterns with carbapenems. We have already given. So on day 4, hemodynamics improving and off vasopressors, MAP was maintaining above 70, lactates 1.6, urine output in last 48 hours was 150 ml. Patient was weaned off on pressure support ventilations with an FiO2 of 0.3, ABG is improving, chest X-ray improving. Day 5, after successful SBT trial with improving AVG, patient was extubated successfully to intermittent NIV, and now onwards on day 5, the patient was shifted to intermittent hemodialysis, resumed alternate days. So our next questions with Dr. Munish Chauhan sir. Sir, when and how should active deresuscitation to perform in such patients with ESR?
Look, if we take a step back and think about the patient, he was not dialyzed for 36 hours before this event started,
yes, sir,
and had a urine output of only 150 per day anyways. So he already was 2 liter positive, or give or take 500 ml at the onset of the disease. After that, even if we have been following a fluid restrictive strategy, we have been giving fluids and hardly any output except for the insensible losses.
Yes, sir.
And as sir also said, just continuing with what he said, we just started fluid removal only when the metabolic parameters had stabilized a bit. So we had a lot of fluid in, and there was leaky capillaries. We had last in Dr. Chhabra's lecture also. So he had, we can presume, accumulated an ample amount of fluid in the interstitium, which is ultimately going to lead to a effect on the mortality as the current data states. So yes, deresuscitation part of therapy and a part of personalized medicine also, as we talk about it. And as soon as the metabolic parameters have, I won't say normalized, but the trending is good, vasopressors, even if they are low, moderate dose vasopressors, and the trends are good and the maps are okay,
yes,
we should actively start thinking of deresuscitation. Already the patient is on intermittent hemodialysis, but when he was on CRT also, we can start with those lesser amounts, but not go overboard. It's not that we have a negative balance 2 to 4 liters in 24 hours. It's over the next few days that we need to chart out and modify our plan.
With the continuous monitoring of
Definitely. We
can worsen,
assess, reassess, and reassess.
Yes, yes. So, thank you to esteemed panelists for their insight teaching, and thank you, sir.
Everyone is requested to kindly receive their mementos from the memento station outside, Hall A, before leaving the conference venue. Thank you. Now, we shift our focus to plenary sessions. I'd like to invite on stage our esteemed chairpersons for plenary sessions.
Dr. Avnish Bhardwaj sir, Professor, Anesthesia, MGMC, Jaipur.
Dr. Sunil Chaudhary sir, Consultant Intensivist at Mohammed bin Rashid University and Hospital, Dubai.
Dr. Shubhranshu sir, HOD and Senior Consultant, Pulmonary Medicine, Jeevan Rekha Hospital, Jaipur.
Dr. Vijay Mathur sir, HOD, Department of Anesthesia, MGMC, Jaipur. Sorry, Vijay Mathur ma'am, HOD, Department of Anesthesia, MGMC, Jaipur.
Dr. Meenakshi Sharma ma'am, retired Dean and Controller, NIMS, and presently Director Medical and Allied College, NIMS University.
So, good morning, everyone. I appreciate and congratulate the organizers for keeping such important topics for the plenary session. No talk or no deliberations in critical care is complete without you talk about sepsis and related aspects. This is something which is very important. It is not only wrecks and ruins the machinery, delays the hospital discharge, and affects the outcome. To enlighten the audience on this, I'll first of all invite Professor Dr. R.K. Singh. Professor Dr. R.K. Singh is a professor of emergency medicine and critical care and head of department emergency medicine. He has done PDCC and several other qualifications related to it. He's in Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, and he is a nodal officer of COVID SGPGI, leadership role in creation of largest emergency in India in SGPGI, leadership role in telemedicine and digital health, and several other leadership roles. His areas of interest are telemedicine, digital health, sepsis, DIC, POCUS, TE, Tele, ED, ICU, and today he is going to enlighten us on a very important topic. Sepsis mimics in critical care between two horns of dilemma. So, Dr. Singh, please.
Good morning, Jaipur. Good morning, chairpersons and all the dignitaries present in the audience. At the outset, I bring a big thank you from the SGPGI and Department of Telemedicine and Health and the Emergency Medicine Department. The topic today, which has to be covered in 15 minutes, I don't know it's running. Okay, the topic today needs to be, please put it on slide mode. Yeah. Please put it on slide mode. Yeah, okay. Okay, the topic needs to be covered in 15 minutes, and there are so many mimics I will not be able to touch in depth in any of these areas, but I'll still try to give an overview of what happens and how difficult it is for an intensivist in the ICU or an ED physician in the ED to discern some of these sepsis mimics from the actual sepsis that is going on. So my talk will go into areas like recognizing it, categorizing it, then diagnostic approach, management principles, quality improvement initiatives that can be taken, and the clinical impact of these sepsis mimics. Now, it is a clinical challenge. Why? Because undifferentiated illness will come to the ED. A more differentiated illness will come into the ICU. So it is easier for the ICU because the diagnosis has already been made, and it is easier for these guys. But when you come into the ED, it is an undifferentiated illness. There is no time, there is chaos, which is imminent in an ED, and then you have to discern between a sepsis and a sepsis mimic. So it is challenging. The presentation is so mimicking each other that it will be difficult for a very novice person to discern some of these areas unless you are experienced enough. And there is variable mortality. Why? Because you will be treating something else while it is actually something else. And most of these patients will invariably be hit onto the lot of antibiotics, which may or may not be required. And because in sepsis, antibiotics is the first thing that is done, and therefore the cost of therapy and everything will be on a higher side in this group of patients. Now, what are the consequences? Consequences will be delayed treatment, unnecessary antibiotics, a prolonged ICU stay, iatrogenic complications, increased mortality, extended recovery, secondary infections, healthcare cost, antimicrobial resistant, and resource inefficiencies. So these are the challenges, if you think in terms of sepsis mimics, that will trouble you when you are in an ED or in the ICU. Now look at the two spectrums. if you're in the ICU, 25% of your patients will actually be sepsis mimics, which you will be treating as sepsis. Look into the ED, it will be almost 40% of these patients, you will treat them like sepsis, but actually there will be a sepsis mimic. So you can very well understand that in the ED, this is going to be more challenging. Why? Because it is an undifferentiated illness. While in the intensive care, in the backwaters of Kerala, you will have a differentiated illness coming into the ICU. Okay? So the challenge is paramount in the ED. Categories, so you will have to categorize some of these. If you look into the broad categories, it could be an endocrinal illness, which is mimicking like a sepsis. It could be inflammatory pathologies. It could be neuropsychiatric illness, metabolic, drug-related, toxicologic, cardiovascular, and others. And each of them has some elements of those illnesses which are mimicking sepsis. So now covering this topic in 15 minutes is a huge challenge for me. So I'll be able to only touch on some of these areas and try and give some clues as to how you can help discern. So thyroid storm, endocrinal, easier for us to understand. So in each of the sepsis mimics, please understand a history taking is important. A physical examination is important. Some laboratory markers will help you out, but you need to have an history taking, proper history taking. And this is something in the intensive care when you work, you probably are hooked onto the monitors and a lot of pathologies and a lot of things going on, but the history is taking a back seat. Well, to discern the sepsis mimic history is very important. Unless you have a proper background of the patient, you will not be able to discern some of these things. And there is so much confusion because they will have tachycardia, they will have fever, they will have GI symptoms. So the only discerning factors will be probably a scoring systems if you don't have time, like a Buch-Watzlawick score. When a point is above 45 scoring points, you will pointer towards a thyroid storm in background of sepsis. Now, since nothing works in silos in the intensive care, one silo will merge onto another silos. So on sepsis, this could be there, and on this sepsis could be there. So then the challenge will become even more. So I am starting point is the entry into the ICU, which I am trying to tell you, or the starting point of the illness when I am trying to tell you. So if you have these simple things at your bedside clinician, then it will help you discern. So a score above 45 will point you towards a thyroid storm in this background where there is tachycardia, high grade fever, GI symptoms, a goiter or a thyroid will help you discern whether it is a thyroid storm or not. I'm sorry I will not delve into in depth because I will not be able to cover the entire spectrum. Second is adrenal crisis. Now in adrenal crisis there are two important elements. There will be a septic shock patient with hypertension. In adrenal crisis and adrenal shock there will also be hypertension. The only discerning factors will probably be hypertension with weakness, fatigue or hyperkalemia associated with that. That will help you. But remember the treatment for both the arms is a steroid. The dosing may slightly differ. In septic shock you try to give 50 milligrams QID with a bolus of 100 milligrams, whereas in adrenal shock you will probably go for a 100 milligram TDS in a dose. So previously we were doing the corticostropin ACTS stimulation test, but of late or for last 2 decades or so, we are not pushing the idea because there is always a relative adrenal insufficiency in patients with septic shock. So the discerning point for me in adrenal shock will be one, again the history. What is the history of this patient? Was he on steroids in the previous year? Is the patient already on a lot of drugs of that nature? Is there hypertension with weakness? Is there hypertension with hyperkalemia associated? So these are simple things which might help me till the time I get better investigative elements into the picture. So as an initial point, this can help me out. Anaphylaxis, again the temporal relationship of the case has to be understood. 0 to 30 minutes to an inciting trigger will be related with rapid onset of urticaria or angioedema. 30 to 60 minutes you can have bronchospasm or hypertension. 60 to 120 minutes you can have potential for cardiovascular collapse. Now in this background you can consider that septic shock could be there. Yes, it could be there, but the temporal relationship is important because if you see the organ involvement, everything can be involved in anaphylaxis. Everything can be involved, but it is the temporality of the event, the inciting intent and the sequence that is happening that will help you discern whether this is a septic shock or this is an anaphylactic shock which is presenting like septic shock to you. And calcitonin might help, might not help, because in say 2 hours duration you are not going to do a procalcitonin every 30 minutes or so. So this is not a great discerner, but yes, if it is very high, septic shock will be a possibility. Bacterial septic shock will at least be a probability in that case. So this might help you a little bit. Neuroleptic malignant syndrome. It is also a sepsis mimic. Now there will be hypothermia, there will be muscle rigidity, there will be altered mental status in this patient. Certain lab findings like elevated CK, high TLC counts and presence of metabolic acidosis. But for sepsis, which we remember is there has to be a source of infection or there has to be a suspicion of infection. So the hunt has to go for finding the source of the infection. If my hunt is going on and I'm not able to find the source of infection, and in this background there is hypothermia, there is muscle rigidity, and there is altered mental status with the background of some neuroleptic medications that this patient may be having, this will become a sepsis mimic. You will have to discern it out in patients with this background. Serotonin syndrome, again more challenging because there will be agitation, tremors, hyperreflexia, fever, diaphoresis. In this background, drugs. If you can find out these drugs which are mentioned like the SSRIs, the SNRIs, TCAs, MAOs, opioids, in a background of all this, there is always a suspicion that this could be having a serotonin syndrome, elevated creatinine, elevated CK levels, leukocytosis, hyponatremia may be prevalent in these patients. And the treatment summary is that you discontinue the trigger. Unless you discontinue the triggering agent, this serotonin syndrome is not going to subside. Cyproheptadine can help you. You can give cyproheptadine to this group of patients. Supportive care will be very similar, except the cooling element that you add on to a serotonin syndrome, because there will be hypothermia and hyperreflexia and diaphoresis and extreme fever in this group of patients. So you will have to look out for this serotonin syndrome in the background of a lot of these drugs. So if you are not taking a history of these drugs and then suddenly a serotonin syndrome is lying in your ICU, you will not be able to discern it. You will always think it is sepsis and keep on pushing antibiotics and antifungals, antivirals and a lot of fluids and everything into this patient. Malignant hypothermia, again a sepsis mimic. Now the trigger, again as I told you, the trigger has to be understood. It is probably an anesthetic agent. A volatile or a succinylcholine can be the inciting agent in this group of patients. This is also a sepsis mimic. Why? Because it overlaps with symptoms of fever and background. And clinical signs, as I told you, are already written. But creatine kinase elevation to above 10,000 levels. So rhabdomyolysis will be prone. So if you're finding a CK which is very high in this patient with this background with an anesthetic trigger agent, it could be a malignant hypothermia case which is lying as a sepsis in your ICU. Okay, so be careful with this as well. DNP poisoning, dinitrophenol poisoning. Now this is it is a banned agent, but with online and internet availability for weight reduction, this is being used. It is available online, and this is a high BMR inducer, very high BMR inducer. It will uncouple the ATP generational elements. Lot of heat is going to be produced in the body. The weight loss is going to be very rapid in this group of patients. So the threshold for this drug between a therapeutic index and a side effect index is very low. So the same dose which is having a therapeutic will have the side effect. So that is why it is dangerous and it is banned. Now with the availability of online, people are buying these drugs. Who is buying them? Bodybuilders are buying them. Beauty conscious females are buying them. Weight reduction drugs. So these are dangerous. This can present like a sepsis mimic to you with all the clinical signs of tachycardia, tachypnea, hypothermia, altered mental status. In the background, you will have an elevated anion gap, high metabolic acidosis, small respiration. So unless again you are not taking the history, you are not understanding the background of this patient, and you are considering him also a sepsis, will be a mimic for you. And the steps of management is obviously decontamination, supportive care, soda bicarb infusion, hemodialysis, and more hemodialysis probably to remove the drug. So beware of this DNP poisoning agent. DK. Patient is DK. I have not taken a proper history. I have not taken the sugar managements. I have not understood that the bicarbs are already less than 15 in that patient, and I have not taken the history of polydipsia, polyuria, or polyphagia in this patient. So if I am not taking all this, this can all present like tachycardia, fever, dehydration, shock. So this is also a sepsis mimic. So DK is a sepsis mimic. Differentiation clues will be you have to find source of infection. Remember, decay in adults, the inciting agent is also an infection inducing a decay. So, infection inducing a decay is a trigger for a decay patient. Okay. So, invariably these patients will be on antibiotics blindly, because diabetic, immunosuppressed, HbA1c out of control, that is why these patients are landing up. And with dehydration, polydipsia, polyuria, if you are thinking only sepsis is the reason and you are not trying to manage the hyperkalemia, the anion gap, the acidosis that is happening in these patients with enough fluid management, again these are confusing. Why? Because you are doing same things for both of these patients. The only discerning factor will be ketone levels in the plasma or in the urine. So, you will try and monitor these ketone values, and there will be a gradual, what we read in Harrison for management of decay, the speed with which Harrison writes the management will be very different from what we do in the intensive care. So, please understand the same Harrison principles when they come on to the intensive care, the speed of management, the speed of monitoring changes, because Harrison is for ward management. Okay. For decay patient lying in the intensive care with multi-organ failure, with renal shutdown, decay is going to be a huge challenge for you. Kidney is not working, I want to give fluids, I want to manage the decay. How am I going to manage the decay if the kidneys are shut down because of dehydration? So, there are a lot of challenges. Harrison does not discuss this. Please read it again, it does not discuss it. Hyperosmolar state coma, again dehydration, background, physical, dry mucus, poor skin, turgor, blood glucose and osmolarity is all going above 320, both osmolarity as well as osmolarity. So, if I am not taking the history properly, everything looks sepsis for an ICU. More than 50 to 60% patients lying in the intensive care, the only diagnosis that comes to the mind of the clinician is, Baba, this is sepsis. This is all sepsis. Everything is sepsis. Everything is antibiotic. Number one diagnosis in the ICU is sepsis. Right? As I told you, 25% of these patients will be mimics. They will not be sepsis. And we will continue to treat them and waste the money, precious money for these patients. So, please understand this. The strategies, if you look, are fluid resuscitation, insulin drips, correction of electrolytes, blood glucose monitoring, acute pancreatitis, a grace. So, unless you understand that the acute abdomen can have acute inflammatory, please understand all of these conditions are acute inflammatory conditions. So, wherever there is inflammation, there is hyperacuteness of the illness, all the signs and symptoms of sepsis can be there. So, discerning between them, some elements of biomarkers can help you if you have a, but in fungal illnesses it will not help you, in viral illnesses it will not help, but still majority is bacterial, so you will have some and a background knowledge that how a patient will of an acute pancreatitis with an elevated amylase or lipase in the background with an evidence of CT with the history again of obstipation and constipation in this group of patients might help you to discern this illness. Treatments may or may not be same. Treatment pathways will be aggressive IV fluids, NPO depending on the stage and the of the acute pancreatitis that he is having. This might help you out. Acute myocardial infarction. This can be a sepsis mimic, tachycardia, but with the background of ECG changes, with the background of troponin clues will help you discern. But remember, I told you two things can be present in the same patient at the same time, and this happens for geriatric group of patients. In geriatrics, be very careful. 2 illnesses or 3 illnesses can masquerade as one phenomena. So, he will have sepsis, he can have MI simultaneously, he can have a pulmonary embolism simultaneously. So, all of them can masquerade. In the adult groups, there can be many things happening, but the illness will be only one. But in geriatrics, there can be many illnesses, presentation may be one. So, beyond 65, just be careful. It is lot of mimicking will happen in these extremes of age groups. Above 65, be careful. Embolism, as I told you, can be a great masquerader because dyspnea, chest pain, tachycardia, everything in the ICU is mnemonic. suddenly something happening, he is a pulmonary embolic central or peripheral, again history, well scoring, or the PERC rules. You will have to probably have an understanding of these things to discern between a sepsis or, and biomarkers, as I told you, will help you. Echocardiography, if you are trained, looking for RV, hyperkinesia on echo, elevated troponins can be cardiac, troponins can be pulmonary. So you will have to have an understanding into these areas. Heat strokes. Heat strokes can present as sepsis mimics. Yes, they can present. And again, the symptomatology will be, again, background. Look at the background. A laborer coming from a heat environment, hot environment, working for n number of hours in the outside environment, presenting to you with hypothermia, tachycardia, tachypnea, altered mental state. Unless you have not taken the proper history, it will look like a sepsis. You are dumping him with antibiotics. Baba, this is heat stroke. Okay, so it will also have endotoxin release and will lead to endothelial dysfunction, will have systemic inflammation. So immediate cooling, target temperature management and monitoring is required to associate. Now these are the difficult areas, which I'll just, I believe I have some time. So these are the difficult areas. I've touched the easier ones till now. These are the difficult. A patient with an autoimmune illness, patient with SLE, patient with vasculitis, presenting like a sepsis. So unless in SLE I don't know the scorings, I don't know 4 out of the 11, 4 are there positive or not, they will all look like sepsis for me. So SLE patients, you will tend to know them only after few days, or when you have done everything about sepsis and nothing is hitting, then you will suddenly realize this could be SLE, this is lying in the ICU. The rash will not be there. Rash is more prominent in the white population, so your darkened skin you may not find it, and you are treating an SLE patient like a sepsis because it is also having multi-organ and everything. So look into the history elements, whether the patient is on steroid, cyclophosphamide, or any of the immunosuppressant agents that he is having. So you will have to look into these areas to understand this. Again, more challenging. I'm just going on, upping up the element. Cytokine release syndrome. Now there are 4 of these which are very difficult. Cytokine release syndrome, the HLH, the MAS, everything looks sepsis. The clue is when there are extremes of cytopenia, when there are extremes of immunosuppressive elements in that history, when there are extremes of IL-6 surges or the CRP levels. So these are simple things that can help you. You are not all in one. Please do not ever think that as an ICU physician you know everything. You know something about organ support and life support. You will probably have to involve the immunologist in this picture because there is a lot of things that need to be understood, and this will be challenging for even the most astute clinician working in the intensive care. He is treating him for sepsis, but this is cytokine release syndrome. This is MAS, this is HLH. So these are difficult terrains. So involve the immunologist because there will be rheumatological illnesses in the background of these patients, and there will be grading you will have to do, support treatments, and there are, again, these are costly management issues. So will have to be understood. HLH, and as I told you, there are for HLH there are criteria for that. So you look into this HLH 2004 criteria, which looks into hyperferritinemia, hypertriglyceridemia, hypofibrinogenemia, splenomegaly, hemophagocytosis in the blood group, in the blood picture, bone marrow. So all of this has to be looked in. Everything looks sepsis. Everything looks like sepsis. Okay. So my last slide is, be a clinician despite being surrounded by monitors in the ICU. Okay. Don't be hooked up onto the monitors. Steto बाहर आया नहीं, ABG ढंग से पढ़ा नहीं, पेशेंट को एग्जामिन किया नहीं, मॉनिटर्स देख के ही आए थे, मॉनिटर्स देख के ही चले गए कमरे से बाहर. एक बार भी हेड टू टू एग्जामिनेशन फिजिकल नहीं किया पेशेंट का. Infection is important even for these scenarios. So patient presentation, look into it. Infection workup, yes, blood cultures have to be sent for sepsis and other things. PCT will help you in discerning. Source of infection has to be hunted out. If you can't find any of these things and you have the time, then you have to think into the vital signs. Could be a sepsis mimic. As I told you, 25% in the ICU is a sepsis mimic. That means every fourth patient is a sepsis mimic in the ICU. Out of every 10 patients coming to the ED, every fourth patient is a sepsis mimic presenting to the emergency. So you'll have to use your common sense more in this group of background, because inflammation is going to be major. There can be lot of non-infectious causes which can mimic, like sepsis. Treat the underlying cause, because antibiotics may not help you here in any of these mimics which I told you. Thank you, gentlemen. Thank you for patient hearing. Thank you. I had only this much time to elaborate on so many things, so please excuse me my brevity of some of the topics that I touched.
Dr. Singh, you have covered and pointed out two very important points. First is history taking. Yes, very important aspect of our management. Proper history taking, not covering the important points, but taking the history in deep is very important for proper diagnosis and treatment. Second point you pointed out, clinical examination of the patient. I would like to say, machines can fail, but we cannot. So we should examine the patient clinically. Thank you very much. Nice presentation.
Thank you. I can leave the stage?
Yeah, thank you very much. Good morning. I would like to invite Dr. Sachin Gupta. He is Director, Critical Care Medicine, Narayana Super Specialty Hospital, Gurugram. He will be presenting from resuscitation to de-resuscitation, can focus, personalize the transition. Dr. Sachin Gupta.
Thank you, Chairpersons, and thank you, Jaipur team, for having me here. So the topic that I would be covering today is how point of care ultrasound can actually help you in first deciding how much fluid to give, when to give, and the most important question is when to stop giving fluids. So we all know that fluid therapy is a double-edged sword. We consider this as a life-saving power because early aggressive fluid resuscitation is a very important aspect for category of all categories of shock, and more so for when we talk about distributive shock or septic shock. The premise is we want to restore the tissue perfusion, we want to maintain the blood pressure, and eventually we want to support all vital functions. But there is a hidden danger. Fluid is a drug, understand it is just not anything else, it is an important drug. So as all drugs have their side effects, similarly fluid also have it. And so excessive fluid administration would lead to interstitial edema, pulmonary congestion, organ dysfunction, and can increase mortality in intensive care units. We are aware that patients with positive fluid balance by the end of third day of intensive care has a very high mortality compared to patients who are equibalanced by the third day of intensive care unit. So if you look at the data, almost 40% patients of ICU land up with interstitial edema, and this is with best of your practices. So it means it is a hidden danger. We generally neglect or we just have an oversight on this part of intensive care. If that is there, then there is an increased mortality. This is cohort to cohort comparison. There is a 19% increase in mortality in patients who have a positive fluid balance by the third day. So edema is just not about appearance, it is not cosmetic in nature. It impairs ventilation, reduces your drug absorption, it limits the patient mobility, and obviously when all this is happening, there is a very high chance of increase in the ICU length of stay. And so this will have a cumulative effect on patient outcome, and this has been documented. Now there are certain myths about fluid therapy. We always feel, okay, this is septic patients, give fluids. This is low preload, by whatever technique you are checking, give fluids. There is some insensible loss in all septic patients. Surgical patients by default are always hypovolemic. And if you have given fluids and you develop edema, don't think anything else, just give diuretics. These are all myths. They don't work it like this. you actually have to look at what is your intravascular volume, what is your interstitial volume, how do you decide this, and just by looking at the patient, we will never be able to reach that answer. And so we also need to consider why this transition is important from resuscitation to de-resuscitation. And as I said, fluid are drugs. So there are four important questions that one should ask before administering fluid to any category of patient. When should I start fluid? When should I stop fluid? Once I have stopped, and if I feel that this is fluid overload, when should I start removing fluid? And then the next important question is, when should I stop removing fluid? So we know that there is an initial resuscitation phase where we give aggressive fluid administration. Then we try to recognize that is my fluid administration adequate. So there is a recognition of adequacy, and how do we determine? We look at organ function. So is there an adequate urine output? Is there a lactate clearance? Is the blood gases becoming better? And then is there any new requirement in oxygen? If that is there, then we start thinking about active de-resuscitation. So we are all aware of the side effects of fluid accumulation, and it does not spare a single organ in our body, whether that is abdominal wall, renal, hepatic, gastrointestinal, cardiovascular, respiratory, and even central nervous system. Again, this depends on the degree of the fluid accumulation that is happening in these patients. The second important dilemma that we have is, see, by looking at the dynamic indices of fluid resuscitation, we can actually come to know who is fluid responsive. But every patient who is fluid responsive may not be fluid tolerant. That means patients with leaky capillary syndromes. Now you give fluids, what will happen? Some amount will leak into your interstitial fluid, some amount will leak into your alveoli, and what you start developing is wet lungs. The oxygen requirement starts increasing. So these are fluid non-tolerant or intolerant patients. They are fluid responsive. So this category of patient again is very, very important, and when we look at our conventional modes of assessment, we will diagnose them at very late in the clinical state. So this critical distinction highlights the need of a sophisticated assessment tool, because we need to evaluate both the cardiac preload responsiveness and also the patient's capacity to tolerate additional fluid without developing harmful congestion. And this is where our point of care ultrasound comes into the picture. Now, if we have this kind of appearance to start with, so I will not be talking much about ultrasound, as in this is not a teaching class, but if you are aware, then we always look at our lung, we look at the heart, and we look at the IVC, and then we look at the information that we get from these three aspects, and we cover it together. So if I have to talk about this, this is a lung which is sliding, and we call this as an A pattern. Now this represents aerated lung, which is not wet, which means an option of giving fluids, provided this patient should be fluid responsive. So this is one part of my assessment. You look at your echo and you look at what is the cardiac function. You can just do an eyeballing for an intensive care unit, and you see that my heart is beating fine. The third important aspect that you look at is the IVC collapsibility. My IVC is collapsing, which means I have a preload deficit, my lungs are dry, my heart function is fine, this patient is fluid responsive, provided this patient is in shock. Yes, you can administer fluid. So you don't just look at an IVC and decide, fine, I will give fluids or I will not give fluids. You always have to look at all three these functions. And so if I have to say, we'll say dry lung, empty heart, and a variable IVC, I will give fluids. And this is where the concept of resuscitation, optimization, stabilization, and de-escalation or ROSD developed. And at every single step, your ultrasound will be a modality to assess and reassess when should I stop giving fluids or when can I give fluids. So we look at our lung ultrasound, we look at focused cardiac ultrasound, then we look at signs of congestion. So we look at our hepatic, portal, and renal ultrasound, which is known as a Vexus score, and we also look at the IVC collapsibility, and the patient is ventilated, then we look at distensibility. So we evaluate the cardiac function in the IVC collapsibility to predict whether fluid administration will increase cardiac output. That's the important thing. Then if we are giving fluids, we always have a close watch on our lung functions. What is the pulmonary status? What is the lung ultrasound? Because we don't want an A pattern to start getting converted to a B pattern, which means now there is leak of the fluids and my lungs are getting de-aerated slowly and slowly. We also look at the level of venous congestion. So if my IVC have reached a particular size, we look at what is my hepatic, portal and renal vein Doppler patterns. And if those patterns suggest that there are signs of venous congestions, we start with an optimal timing of diuretic therapy, and again diuretic therapy again have to be monitored based on these Doppler signals. So you do your passive leg raising in your intensive care unit. I know the beds are very specific. When you do a passive leg raising, you can't touch the patient. So let's say you are not able to do that. Fine, don't do that. You can actually just tilt the bed from an head up position to a head down as much as possible with the help of an esophageal Doppler if you have it, very well. Even if you don't have that, just put a cardiac probe to look at velocity time integral. That will show you the change in the cardiac output. May not be showing the number that it says, but still it shows you the change in the cardiac output. If that is there, which means my patient will tolerate some amount of fluid. We look at the carotid artery velocity time integral. So generally we were doing an echo, but now the literature is available. Even carotid artery VTI is sufficient enough to determine what is the fluid responsiveness status of my patient. And in mechanically ventilated patients, again you can look at your PPV with the help of the POCUS. So when you started giving fluids and you start developing this kind of phenomena where the lungs have become wet, the heart becomes hypokinetic and the IVC is plethoric, your patient is still hypotensive. This is not the time to give more fluids. This is the time to add vasopressors, because now your patient is not fluid tolerant, maybe fluid responsive, but the patient's tolerance to the fluid is not there. So no more fluids to this status. So this is the point where I would say my resuscitation has reached an end point. I have to stop giving fluids, and probably I will have to think about de-resuscitation here. Even patients with massive fluid resuscitation can develop pleural effusion. They can have free fluid in the abdomen. Again, this is a sequelae of massive fluid resuscitation that happens. The fluid seeps out into all cavities. The other way of judging what is the end point is you start looking at your diastolic functions of the heart. So see, every patient will not have a diastolic dysfunction. When you get a routine echo done in your ICU, they would write grade 1 DD. DD means diastolic dysfunction, or no DD. Always have a basic echo done for all patients who land up to the intensive care unit, whether they require fluids or they don't require fluids. At least you will have some baseline finding. When you start giving aggressive fluids and when you reach a point where probably you're not sure whether to give more or not to more, always look at your diastolic dysfunction. Is fluid resuscitation causing a diastolic dysfunction? And this is the first marker that will come to picture, unless, and then you will have signs of fluid accumulation in terms of B lines, in terms of pleural effusions, ascites, some element of pericardial effusion, edema, anasarca. So always assess your diastolic dysfunction, and there are various grades of diastolic dysfunction, and we calculate the E by A ratios, and so I will not touch this topic, but people who are aware of how to do a echocardiography, and this is very, very simple to do it, we should look at diastolic dysfunction. Velocity time integral, it is the best non-invasive hemodynamic monitor that is available till date. Yes, you can have invasive hemodynamic monitors, but to judge the fluid responsiveness, whenever we give fluids, we always follow the Frank-Starling principle in our head, that if I am giving preload, there will be an increase in the stroke volume. But how do you draw that on a patient? So what we say is, give fluids and look at your VTI. VTI is a surrogate marker of your stroke volume. With every variability, if the fluid is, when you're giving fluids and if there is a change in the VTI and that variability is around 10%, which means it's a surrogate marker of fluid responsiveness. So if your VTI waveforms have a 10% difference, it means you can actually give fluids to these patients. These patients are in the ascending part of the Frank-Starling. I was talking about Frank-Starling. So if you have this kind of finding on an echo, which is a short axis view where we see the LV diastole is actually totally emptying the heart, you give fluids. If there is an increase in the diameter of the heart at the diastole, which means my patient is fluid responsiveness, you again give fluids, you have an increment in the diastolic area, you give further fluid, now there is no increase in the diastolic area. This tells me my patient has actually reached the plateau part of the Frank-Starling, and I need to stop here as fluid resuscitation maneuver. So this is how you decipher and draw the Frank-Starling on a patient. When we talk about fluid overload, we always are aware that This can lead to all organ failures, which is hypoxemia, liver failure, kidney failure with elements of fluid overload. And so to assess this, the protocol which came into the picture was VEXIS, where the first step was an IVC assessment, where we looked at IVC and the caliber has to be more than 2 centimeters. So that is step number 1. If your IVC is not more than 2 centimeter, you stop then and there. But if your IVC crosses 2 centimeter and beyond, then we go to further assessments where we look at the hepatic veins, portal veins and the renal veins. So this is how the IVC should appear on an ultrasound, as horizontal as possible. You can easily see the hepatic vein insertion here, right? And we measure this just 2 centimeter below the RA and the IVC junction, and or just around the hepatic vein and the IVC junction, right? So this is how the hepatic vein should appear, and this is the IVC. Then the next step is the hepatic vein, portal vein and the renal vein analysis. And in the ultrasound workshop, we had a talk on VEXIS. So again, the same thing is there. For the hepatic vein, you look at various Doppler patterns in hepatic vein, that what is the variability. So you have an A, S, V and D wave, which represents the atrial contraction, ventricular systole and ventricular diastole. So if there is a reversal or is there a size change, on the basis of that we comment about congestion. For portal vein, we look at the pulsality, and for the renal vein, again we look at the reversals here, right? So this is how you put it all together. The first part is what is normal. There is no congestion here. Here the S wave would be smaller than the D wave. In this, the severe congestion, we have a reversal of the S wave. In portal vein, we have this kind of pulsality, and which is around 30 to 50%, and if it is more than 50%, we say this is severe congestion. Similarly, for intrarenal vein or the arcuate vein in the renal parenchyma, we talk about the S and D reversal, and then you have a complete reversal, which is about moderate to severe congestion. Then, as I said, lung ultrasound is important because you want to see from an A pattern to a B pattern. And what does B pattern represents? They are vertical hyperechoic artifacts, and they represent thickened interlobular septa which is filled with fluid. So presence of B lines is equal to D aeration, as simple as anything. B lines are always pathological in nature, they are not normal. So we always look at quantification, and when there are international guidelines which are published in 2012, again the number of B lines represents the degree of deaeration. So more the B lines, more the deaeration, and this is how you base your therapy. So once you start your diuretic or your let's say non-invasive ventilation, and you see there is a decrease in the B lines, it means more and more lung is getting aerated now. So this is the quantification that we look at. So as I said, if from this part to this part you are going, there is an increase in the wetness which represents deaeration, and if you are able to manage it in a reverse manner, it represents aeration. So our clinical practice should be, if we have reached somewhere here, you start your diuretic, you start your other therapies, so that less and less number of B lines start appearing. And this is a lung ultrasound aeration and a deaeration score, a very widely practiced score, and there are points which are given. We say from B1 to B2 to normal to consolidation, and this is based on this figure itself. So it is a vital tool, and we need to understand, we are talking about precision medicine nowadays. We always do a tailor-made medication or a tailor-made prescription for all patients. So POCUS helps us in individualizing the fluid requirements of each patient. See, surviving sepsis is 30 ml per kg. That's not sacrosanct for all category of patients. Patients, let's say, with poor albumin status, patients with liver disease, patients may not tolerate that volume, right? So it enables individualized physiology-driven fluid therapy tailored to each patient's need. We successfully are able to balance resuscitation, which is life-saving in nature, to actually fluid overload, which is created by us when we do this aggressive fluid management, and it demonstrates the fluid de-resuscitation, because that is important when it comes to survival. We want an equibalence by the third day of all our intensive care admissions. Thank you so much.
Thank you, Dr. Sachin, for very much informative session here. And really, we have to treat fluid in the ICU as a drug, not a fluid like. It's like a drug. Right. So we will consider this like this, then we will be more optimize the patient. So thank you so much. Thank you, Dr. Sachin. Now I will cordially invite Dr. Saurabh Taneja. He is a senior consultant critical care medicine, Sir Gangaram Hospital, New Delhi. He will present the session on the right ventricular dysfunction in critical illness, the silent culprit. Please, Dr. Saurabh, please.
Thank you so much for inviting me here. And it's a real pleasure to be in the pink city of Jaipur and to have such illustrious people around me. So I'll be talking about right ventricular dysfunction in critical illness. And over the past 2 decades, the focus has slightly shifted to right ventricle. It is being given its due importance. So the topics that I'll be covering is why is right ventricular anatomy so different from the left ventricular anatomy? What is the physiology? What is the mechanism of right ventricular dysfunction? Can you think about it and how can you diagnose it? And how do you manage it? And it's not an easy thing to do, not even with the best of the places at the setups. So the main difference between the left ventricle and the right ventricle is very important to know. The left ventricle has significantly thicker and more muscular walls than the right ventricle because it pumps the blood into the high pressure systemic circulation, whereas the right ventricle pumps it into the low pressure pulmonary circulation. This basic fact is very important for all of us to realize. Then RV by itself can achieve a greater end diastolic volume and surface area as per volume of blood in order to reach an equal stroke volume. So stroke volume is equal, but the way right ventricle contracts as compared to left ventricle is very different. There are longitudinal fibers which are moving from the tricuspid area to the apex, and there is a longitudinal contraction. Then there is a 20% of the contribution is by the intraventricular dependence or the septal contraction. So this is how the right ventricle wraps around the left ventricle, and you can realize the right ventricle free wall thickness is only 2 to 3 millimeters, whereas the left ventricle free wall is 8 to 11 millimeters. But still the right ventricle pumps an equal amount of blood because of the longitudinal thickening and because the intraventricular dependence, which I will be talking about in a lot of detail. So the shape is concentric. The structure, there are 2 layers of fibers and the inner layer is a longitudinal one. It's a low pressure, low resistance ones. The stroke volume is the same and it adapts to the preload very much easily. But what it cannot adapt is to the afterload because it is actually pumping blood into the pulmonary circulation and the pulmonary vascularization is very low. So the myocardium, when we say it's a thin and compliant myocardium, it is adaptable to preload, whereas the left ventricle is adaptable to the afterload because it is pushing blood into the systemic circulation. So the difference between the two circulations is very important and I am highlighting it again. The ability of the lung to recruit partially collapsed or unused vessels as cardiac output increases, and the relatively low degree of vascular motor tone in the proximal pulmonary vascular bed. So this is very important, and that is why the afterload, if it increases by due to pulmonary hypertension, pulmonary embolism, any cause leading to increased afterload for the right ventricle, finds it very difficult to adapt, and then it leads to right ventricular failure. It's one of the most important causes and most important triggering factors for the right ventricular failure. So when we exert a lot, if the cardiac output increases, if we have a run, what happens is that the right ventricle, it finds it difficult to adjust. So on the other hand, the more compliant right ventricle is better suited to accommodate large increase in right-sided venous returns, but tolerates the afterload very, very poorly. So this will tell you exactly what is there. So if you see on the figure on the left one, so when the stroke volume, if you see that if the right ventricle, the pressure of the mean vascular pressure is increased from 20 to 30 millimeter of mercury. Okay, so is there a pointer? Oh, thank you so much. Sorry. So this is the right ventricular trace and this is the left ventricular trace. So the right ventricular stroke volume falls sharply. So the stroke volume decreases only when the pressure is increased from 10 to 20 to 30. So this slight increase in pressure leads to a large drop in the stroke volume in the right ventricle, whereas the left ventricle can adjust very easily to increase the pressure. Similarly, in contrast, the left ventricular stroke will increase rapidly as the left arterial pressure is increased. So when the right ventricular, it is okay to have a preload, but it is very difficult to adjust to a afterload. So this has been seen, and this is the premise of having a right ventricular failure when we have things like hypoxic pulmonary vasoconstriction, hypercapnia, acidemia, even deleterious effects of the mechanical ventilation when we have increased PEEP. So I'll be telling about that. Another thing is we should know is interventricular dependence. So it's a phenomena because the ventricles have a common septum, and it is a result of the direct mechanical interaction of sharing the common interventricular septum and the pericardium sac. So if we have a pericardial tamponade, that is also affects the right ventricle contraction. So there is a systolic ventricular interdependence and there is a diastolic ventricular interdependence, and let us see what happens when it fails. So when right ventricular end diastolic pressure is more than the left ventricular end diastolic pressures, what happens is the septum shifts towards the left ventricle during the diastole, creating a flattened septum and a D shape. So this is how it happens. So when there is a right ventricular volume overload, there is a flattened septum. So this is the normal thing. The right ventricle wraps around the left ventricle. But when there is a volume overload or a fluid overload, a right ventricular failure or dysfunction is happening. So this septum shifts from the towards the left ventricle and compresses the left ventricle. This can also be because of the increased pericardium constraints like pericardial effusions or pericardial tamponade. And this diagrammatically tells us about whether the right ventricular volume and pressure overload happens and how the ventricular interdependence actually puts the left ventricle under also a lot of strain. Now when we talk about causes of RV dysfunction, so the causes can be abnormal preload, increased afterload, altered rhythm, a reduced contractility, or a altered interdependence. So afterload is one of the most important causes, and that is why the most emphasis is given on the increased afterload, and this can be because of the pulmonary hypertension, as well as the left ventricular left-sided disease, or pulmonary embolism, pulmonary hypertension leading to systemic causes, acute lung injury or ARDS. When the patient is in ARDS, it can have an acute right ventricular dysfunction. Then even the patients with obesity, hypoventilation syndromes or the sleep-related bleeding disorders, they can also have right ventricular dysfunction. So it is actually a important thing because more and more patients, more and more people are being recognized by the right ventricular dysfunction nowadays. Then reduced contractility. So decreased blood flow to the right ventricle leading to right ventricular injury or ischemia or infarction, myocarditis, cardiomyopathies, these can all be a causes of reduced contractility. Then abnormal preload. So it is very difficult to balance the preload correctly in with right ventricular failure. So hypo or hypervolemia can both cause right ventricular dysfunction. Then pericardial tamponade or altered rhythm can be leading to right ventricular dysfunction by itself. So these again diametrically tell you that even in patients of sepsis who have endotoxinemia, endothelial dysfunction, left ventricular dysfunction, then they have hypoxic pulmonary vasoconstriction. So right ventricular dysfunction even in patients of sepsis that we deal day in and day out can also be recognized much more commonly. Then a very important thing which we often don't realize that hypoxia and hypercapnia, they both can significantly worsen RV dysfunction. So it has been studied, we have in ARDS patients we allow CO2 to go up and we actually have to deal with hypoxia. These can actually worsen the RV dysfunction, and that is why more and more RV dysfunction is being recognized nowadays in patients of ARDS and sepsis. Hypoxia by itself has a negative inotropic effect, and when we give mechanical ventilation, so increased intrathoracic pressure by giving PEEP or high tidal volumes can increase the intrathoracic pressures and pulmonary vascular resistance, thereby increasing the RV afterload. Whereas reduced preload can be there because of mechanical ventilation, and both of them can lead to RV dysfunction or RV failure. So this is how RV failure happens in case of obstructive shock. So the signs and symptoms of RV failure are due to dependent edema and ascites, but that happens more in patients who are in wards. Liver congestion, so sign lead to impaired liver functions can also be there. So any organ back pressure changes, increased JVP, they can all be causing because of right ventricular failure. So this is the highlight in the patients who actually come in the wards or in the clinical OPDs, but when we have a patient in critical care settings, we can see edema, ascites and distended neck veins and hepatomegaly more commonly. So how do you diagnose right ventricular dysfunction? We know the clinical signs and symptoms. The most important thing that we nowadays have is the transthoracic echocardiography, in which we actually measure the TAPC. Nowadays we don't put pulmonary artery catheters, so we can actually these many indices. Many minimally invasive cardiac output techniques are there which can actually tell us a lot about this. But enlarged RV can actually recognize very easily on a transthoracic echo. We can see a size of the RV which is taking more than the half of the heart size, a septal flattening, a reduced motion of the RV wall and a dilated right atrium. TAPSE, which is a very easy to do and a highly reproducible thing, which is a tricuspid annular plane systolic excursion, and if it is less than 1.7 centimeter or 17 mm, the chances of RV failure are very much high. So these all things can be recognized very easily on the echo. Enlarged right ventricle, dilated RV, so you can see the dilated RV as compared to the LV, the septal flattening, increased IVC. Then specifically for the clot, you can see a clot. Then there is an acceleration time of the pulmonary ejection and 60-60 ratio it is called. So this also tells us about, so mostly they are focusing on right ventricle and the tricuspid valve. Now how do you manage such a patient? So you have to optimize preload, which is one of the most difficult things to do here. Right ventricular afterload reduction, treating the cause. So if you can treat the cause, if it is treatable, or at least treat the triggers like hypoxia, hypercapnia and acidemia, you will actually help out the patient. Then you can give a mechanical circulatory support. So usually what happens, the patient who comes to us comes with a patient, it's not a simple patient. He'll come with core pulmonary emphysema and then he comes to the ICU with pneumonia. Or a patient who's having a chronic right heart failure comes to become with septic shock. So these are the patients you actually need to manage in these patients. And management should be directed towards optimizing right ventricular function while reducing the causes or the triggers. But if the patient is actually of pulmonary embolism, you can treat the cause. So if it is an acute setting, it is easy to treat. So the treatment becomes, we actually try to restore the perfusion pressures. Again, noradrenaline is the first vasopressor of choice. We give volume bolus if we find that the preload is actually benefiting the patient. But in some patients, the patients are actually fluid overloaded, we have to give diuretics. So by doing a transthoracic echo and repeatedly doing it, we can actually find out the patients in which we actually need to decongest these patients. This I have already covered, but this is a very important thing. Some patients, sequential echo is very important. If this is a patient in which you have sequential echo, in which you can actually treat them. If we have a biventricular failure, we can actually think about inserting a pulmonary artery catheter in these patients, because we have to be very careful in which patients to give more fluids, which are preload responsive, and which are the patients who are having, we can give diuretics and even institute ultrafiltration to take out fluids. But remember, the RV has a flatter Starling curve as we saw, so considerable amount of volume unloading will actually have to happen to see a RV function improvement. So chronically, if you do a ultrafiltration, if you do it for few hours, then only you can see improvement in the RV functions. Then afterload reduction. So excessive afterload is one of the most important cause, as I told you, and simple triggers can be removed like hypoxia, hypercapnia, acidemia. But if you are not important, we can actually think about increasing the, giving pulmonary vasodilators to decrease the increased pulmonary vascular tone in these patients. So interventions should be, we have to maintain the basic ventilator settings and try to not give too much high tidal volume in these patients. We can restrict PEEP as much as possible, except in the patients of ARDS, in which we actually have to give a higher PEEP to recruit. Then try to avoid tachycardia, because this can actually increase the work of the cardiac work and lead to RV dysfunction. So again, the vasopressor of choice in which to increase the RV contractility is still norepinephrine. Other vasopressors are also there, but usually they are, all the inotropes that are given are usually combined with a vasopressor in these patients. Then about mechanical support. So there are newer supports which are implantable right ventricular assist devices and ECMO which are being used in these patients. So they can actually direct the, they can bypass the RV, and these are the patients who can actually be taken up if it's not acute care for heart transplantation. V-ECMO has been tried in many patients. So this actually emphasizes how do you manage a RV failure. You have to actually do a echo and find out whether the excessive preload is the cause or decreased preload is the cause. If there is excessive preload, try to diurize the patient or do a ultrafiltration. If the patient is having excessive afterload, we have to treat hypoxemia, acidemia, and we have to decrease or at least give an optimum PEEP in these patients. We can think about giving pulmonary vasodilators, but it's a double-edged sword. We can try to give anotropes with vasopressors, and if everything fails, we have to give for extracorporeal life support or assist devices. So thank you, Jaipur Criticon. Thank you so much for having me here.
Thank you, Dr. Taneja, for an excellent talk, and all the three lectures have been very nice, and I'm sure there are so many questions left on. I'll take guidance from the organizers because we are running behind the schedule, and inaugural function is was scheduled at 11. So do we have some time for any question? No. Okay. Okay, fine. So I already see the chief guest and good friend amongst the audience, and any comments from the chairperson? So we come to an end of this session. Thank you very much.
Everyone is requested to kindly receive their mementos from the memento station outside Hall A before leaving the conference venue.
Let's illuminate the new beginnings and join us for inauguration ceremony followed by lamp lighting.
So I'd like to invite on stage our respected patron,
भारद्वाज और मेरे साथ डॉक्टर तनु अग्रवाल का हम आपकी बहुत बहुत
एक और दे दो, ये हटाओ, इसको हटाओ, हटाओ इसको, ये फटी हुई है, फटी हुई है, इसका कपड़ा फटा हुआ है, कपड़ा फटा हुआ है, इसका कपड़ा फटा, इसको कॉर्नर में रखो, इसको चेयर को और दो, इसको सही हो जाएगा थोड़ा।
मैडम ये भी देना कि ये वाले पानी को
मदन मदन
सबको बुला लो, खाली क्यों है हॉल?
लैम्प बीच पे रखो ना।
बोला वो लेन बीच में कर दे।
Hello.
Let's illuminate the new beginnings and join us for inauguration ceremony followed by lamp lighting.
I would like to request our respected patron, Dr. Manish Munjal sir, to kindly come on stage, and
I would like to invite our chairman, Dr. Mohit K. Roy sir.
our respected secretary, Dr. Nikhil Ajmera sir,
Our treasurer, Dr. Chandrasekhar Gaur sir.
our special guest, Dr. R.K. Mani sir,
And Dr. Sachin Gupta sir.
our scientific committee, Dr. Arun Sharma sir,
Dr. Kishore Munjal sir. Mangal sir. Kishore Mangal sir.
and our chief guest, Dr. Vinay Joshi sir.
And our guest of honor, Dr. S.P. Sharma sir.
I would like to request our dignitaries to light the lamps and inaugurate the event.
मैं बोल रहा हूँ हाँ आ रहा है हाँ
I would like to request all the dignitaries to kindly let's illuminate the new beginnings. I would like to request our dignitaries to kindly proceed with the lamp lighting. Please, sir.
Good morning to the August gathering here. Good morning, respected dignitaries on the dais, seniors, colleagues, and dear friends. On behalf of the organizing committee of Jaipur Criticon 2025, it gives me an immense pleasure to welcome you all to this academic celebration here in our beautiful Pink City. The theme of this year's conference is Emerging Critical Care from Instinct to Intelligence, perfectly captures the evolution our specialty is witnessing. Critical care has always been a high technology and high demanding branch, one that requires us to remain alert every second, interpreting subtle physiological changes and making split-second decisions that can define outcomes. For decades, our practice has been guided by clinical instinct, that art that blends the experience, observation, and compassion. Today, that instinct is being powerfully complemented by intelligence that is called as the AI, artificial intelligence. We are moving from reaction to prediction, from retrospective reviews to real-time insight, from data collection to data interpretation. AI is helping us recognizing patterns before crisis develops, optimizing ventilation, anticipating sepsis, and personalizing therapy as per the patient requirement. Not replacing our judgment, but refining it. Yet, even in this stage of algorithms, one truth endures. Technology may enhance precision, but it is the human compassion that completes the care. Yesterday, we began with Jaipur Criticon with vibrant pre-conferences workshops that covered every key pillar of intensive care, whether it's ventilation, airway, hemodynamics, ECMO, CRRT, critical care nursing, and ECMO. The participation and enthusiasm were phenomenal, and I sincerely thank our expert faculty and delegates for making them such a success. Our today and tomorrow scientific program will carry out the momentum forward with lectures, panel discussion, and debates on topics that includes AI in the ICU, sepsis, shock, ECMO, and other things. We are privileged to have you with us and the stalwarts who laid the foundation of Indian critical care and innovators who are shaping us for intelligent future. Once again, I welcome you all for this Jaipur Criticon, where instinct with intelligence and the future of critical care begins today. Thank you. Now I request the chairperson of Jaipur ISCCM, Dr. Mohit Roy, to say a few words.
Good morning, respected faculty, distinguished guests on the dais, colleagues, and dear friends. At the outset, it is my pleasure to welcome you all to Jaipur Criticon 2025, which I think is a celebration of science, skill, compassion, which defines the spirit of critical care medicine that we practice. On behalf of ISCCM Jaipur, the current EC, and the organizing committee of the conference, I would like to express my heartfelt gratitude to all the dignitaries on the dais, to the chief guest, Dr. Vinay Joshi, sir. Thank you for joining us, sir. Guest of honor, Dr. S.P. Sharma, sir. Thank you, sir. Dr. R.K. Mani, our special guest for today, one of the veterans of ISCCM, past president, and also an authority on end-of-life care, who has actually spearheaded end-of-life care in the whole country. Dr. Sachin Gupta, who is the Secretary, General Secretary, ISCCM, central body, and we are privileged to have you here, sir. Our patron, Dr. Manish Munjal, and Dr. Shabbar, who is not here with us today for certain personal commitments, last minute. I thank you all for your support all the way. Dr. Munjal and Dr. Shabbar have been the foundation on which a branch has built itself. This year's theme, Emerging Critical Care, from Instinct to Intelligence, it reflects a shared mission to blend innovation with humane, patient-centered and yet smart critical care, which transforms knowledge to personalized bedside care. Ladies and gentlemen, critical care is one of the most dynamic and demanding fields in medicine. Each day we balance technology with empathy, precision with intuition and knowledge, with deep responsibility of caring for the most vulnerable patients. Over the coming sessions, we will hear from leading experts, discuss new frontiers in organ support, and explore how teamwork and communication can transform outcomes. You will also hear why and how we as healthcare workers need to take care for ourselves while we care for our patients. I hope and trust that each session will give valuable insights to each one of you. I also extend a heartfelt thanks to our speakers, many of whom have traveled quite a bit, our sponsors, and also congratulate, most importantly, my organizing team, especially Dr. Nikhil Ajbera, Secretary, Dr. Chandrasekhar Gaur, Treasurer, Dr. Arun Sharma and Dr. Kishore, who are our scientific chairs, Dr. Ashish, Dr. Pankaj Anand, who is a workshop director, Dr. Anil Sharma, and many, many others whom I probably may not name, but they are very integral part of whatever we have done and whatever successes that we have had. So, and to all the OC members who have worked very tirelessly to curate this event to the minutest detail, for their dedication and for their hard work, and of course, in the end, and most importantly to all of you, for being part of this vibrant community committed to excellence and learning. I wish you all an engaging, thought-provoking, and inspiring conference ahead. Thank you, and welcome once again. Thank you.
Thank you, Dr. Mohit. Now I would like to request Mani sir and Munjal sir to felicitate our chief guest, Dr. Vinay Joshi sir. Big round of applause for him. He's the chief guest with shawl and bouquet. Dr. Joshi is the former principal and controller at Jodhpur Medical College, a pioneer in anesthesiology and critical care. Taliyan bas deni chahiye, please. Who established some of the earliest ICU services in the Western India and has mentored generations of clinicians. He has been a visionary administrator and teacher, knowing for building strong academic institutions and inspiring innovations in the intensive care education. Dr. Joshi's unwavering commitment to the clinical excellence and ethical medicine continues to guide us young physicians across the state. Thank you, sir, for being there. Dr. Vinay Joshi. Now, I would like to request Vinay Joshi, sir, to say a few words. Mic वैसा वाला दे दो. हाँ. नहीं आप इधर चलेगा.
Good morning, every delegate and the organizers. Now, the honor to be the chief guest of this function should go to my students and my colleagues because they made me so busy in day-to-day activity, and they taught me by asking the questions how this is happening and why this is not happening. So onwards, my journey went onwards. But briefly telling about the history of critical care in Rajasthan, probably Jodhpur Medical College was the first college in North India to start one-day ICU bed in 1978. And the ventilator which we had was Bird's ventilator. So that was flow generated, and the second norm was to keep inspiratory and expiratory ratio. So then in 1990, by the help of the finance secretary, which happened to be the Jodhpurian, and one of the relative actually got admitted in ICU, and he came to see him, and the amount of care given by our colleagues, he praised like anything, and then he rose the fund, he snatched the fund from the government, and then we established 4-bedded ICU with all modern gadgets like railroad, by central gas lines, by good ventilators, good cardiac monitors, the bed alarm, and everything. Almost everything was available at that time. And then in 90 onwards, I spent my whole time in critical care. I left going to the OT and I spent there. In 95, I went to Saudi Arab on the direction of the government. So I stayed there for 1 year. Fortunately, I was also had fortune to work in ICU setup of Saudi Arab. I came back, then I was posted in Kota, then back to Jodhpur, back to Kota, and then on promotion as a professor, I came to SMS Hospital, Jaipur. So I had the nostalgic feeling about coming to Jaipur anytime when I came here. और गुलाबी शहर है तो थोड़ी गुलाबी ठंड भी आपको महसूस हुई होगी. तो ये गुलाबी शहर है, यहाँ की महक अलग है, यहाँ की चहक अलग है, और यहाँ की चपलता व हंसी खुशी प्रसन्नता भी अजीब है. But now I want to come on to few questions. back in 1912, I read an editorial that was probably from Lancet, that is the ICU is a boon or it is a curse. So still, I think many persons amongst general population will start criticizing the ICU setup. And the main reason behind that is expenditure. The way technology is advancing, I think the expenditure is also going on. Because since last 1 year, I am reading and I am hearing, though there are ARDS protocol, low volume strategy is a boon, definitely, but coming that no, it should be individualized. So from common sense to make it individualized. But again, then you need SCCT. How many of the ICUs can have SCCT in their ICU setup? So these are few questions. Expenditure is really, and you will make differentiation between the government sector and the corporate sector. The government cannot pay you so much that you can really advance your ICUs on good ventilators and all. And about the critical care specialist, I think they are extraordinary because to be an intensivist, you must read all the subjects. Probably there is no other branch which covers specialty as well as super specialty. Because you must know cardiology, you must know neurology, you must know hepatology, you must know nephrology and so on. So probably no other branch and no other person is. But when the patient die, many people say we become killers. But when the patient survive, you become a miracle. You become majestic. So that is the core of the ICU. The third thing which I wanted to speak about, you must communicate with your patient, not only patient, but patient's relative and their dear and near ones. Because they are very curious, they are scared. So if you don't communicate daily, once or twice in a day, is really making them worse. And I think there are many articles which tells you that how many patients develop ICU psychosis. So that is again which I have come to know when I face the patient's relative and their near and dear ones. And it was my practice to talk them at least twice in a day by calling them in my chamber and giving them that this is what your patient is, this is improving, this way it is deteriorating, and this you actually keeps away from worries and tensions and the anxiety. Again, we have seen so many updates and changes in the guidelines. So it is very difficult nowadays to keep update because every day something coming new in an ICU. And lastly, about the gene therapy. So now we are advancing not only the personalized therapy or individualized therapy, we are coming on to with the help of AI and regarding the gene therapy. And that's how we are going to treat in future. That can this patient having this type of DNA and this type of gene will all the stories, all the guidelines, all the protocols which have been made is really going to improve that patient or not, depending upon their genes. And I think हमारी भारतीय संस्कृति और सभ्यता में ये सिखाया गया है कि पैतृक गुण और मातृदेवी गुण तो आपके खानदान से आपको आते ही हैं. So I don't know how the ICU or critical care is going to advance, but I am very thankful to the ICCM. ICCM has made a actually vigorous, tremendous progress in critical care. They have designed the new guidelines and new protocols, new ethics about the patient's care in Indian setup. That's most important. How in Indian setup we can apply the same European guidelines, American guidelines, or Australian guidelines or UK guidelines. I still finding myself the answer of this question, that whether we need the same protocols, same therapy, same ethics in the Indian population, because the Indian population is quite different from the European colleagues and our Australian colleagues or American colleagues. So the nutrition, we have made progress. We have come to the parental versus enteral nutrition, then partial parental nutrition, then about the dialysis, we have come to ultrafiltration, about the slush therapy, and so many things are changing. And then again in nutritional therapy, we have come, we have came through and we have applied the trace element. And later on, the same trace element supplementations were not advocated in every patient. So the critical care specialty is basically not a static branch. It is a dynamic. What you are practicing today, what you are studying today, tomorrow it may be proved wrong, because it's a dynamic branch. It is going to make change in every day. So kindly keep yourself updated, go on improving, and again 3 years for the Rajasthan State Conference organizers. Please, I bless them, I advise them to continue the same spirit and with same efficiency and same. So thank you very much. And I'm particularly thankful to Dr. Arun, who actually forced me to come here. Otherwise, I was not planned to come here. So thank you, Dr. Arun, and my Jaipur colleagues. And thank you. Once again, thank you very much.
Thank you, sir. Now I request Secretary ISCCM Dr. Sachin Gupta and Secretary ICCM Jaipur Dr. Mohit Rai to felicitate our guest of honor Dr. SP Sharma sir with a shawl, bouquet and a memento. He is the Professor Emeritus Department of Anesthesiology, JNU, Jaipur National University, a stalwart teacher, former head of the department, SMS Medical College, and past president of the Research Society of Anesthesiology and Clinical Pharmacology. He has organized several landmark national conferences and conducted pioneering workshops in airway management and ventilation. Dr. Sharma is the recipient of multiple honors, including the Lifetime Achievement Award, and is celebrated for his decade-long contribution in anesthesia and critical care education. Dr. SP Sharma, sir. Now I request SP Sharma sir to say a few words.
Dignitaries on the dais, off the dais, my colleagues, friends and students. First of all, I convey my sincere thanks and gratitude to the all organizers. They invited me to be part of this Silver Jubilee function of the critical care. Here, I can see that last 25 years and before that also, I have seen the growth of this critical care in the Jaipur also, and continuously they are growing and growing. At many times they are, I mean, rather you can say that regularly they are conducting CMEs and workshops, to educate their, I mean, the other doctors in our fraternity. And not only that, I still remember Dr. Nankishore, Dr. Kishore Mangal, all they have done. And now since 25 years, it is a, again you can see these things are doing well, they are doing well. Regarding one thing I will like to say about this critical care, ICU management. Not much to say, only thing is that, as I read in one of the book, the kissing to ventilator is death sign. Means here it was also true in the Jaipur, but sooner we just change this concept by help.
To Delhi, there are at least 5 to 6 hospitals which are in between. So I used to collaborate with every hospital and we used to pay them the bed charge for that day. Because misadventure can happen anytime. Misadventure means a heart may got missing, we may need a CPR, we may need to halt in between. So the best part is to collaborate with the team and first check the safety. If somebody is saying, boss, we need to shift this patient, he is in sepsis, we cannot take care of this patient to the Jaipur. Now the biggest question is whether it's safe to transport. And consent is of very much dynamic importance, and the team should emphasize the better care person in the ambulance itself.
So in transportation, the first thing we have to assess the patient state, that it is transportable or not. First thing is that is most important part. So it's not like that the patient family wants to shift a patient and you are going to shift it. That is not like that. Okay, first of all, you have to assess the patient that is transportable or not. Okay. Second thing, the logistic, equipment, manpower, dedicated team. These are the second part. Another part is, yes, rightly said, sir, informed consent, because legal litigation are nowadays very much increasing. So informed consent should be there. And the dedicated team, actually most of the hospitals, I don't know, they have a dedicated team for transport. You just pick up a nursing staff, you just pick up a technician, you just pick up a doctor and then send. Yes, you pick up a patient and then bring him.
I think Dr.
Just like that.
But I think already emphasized on these things. So shall we move further in the discussion?
Yes. Just want to add one thing. हम लोग जब गंगाराम में होते थे, Dr. Sharma होते थे. Dr. Sharma was the refined clinician, transport clinician, we used to say. तो सर बताते थे,
as you talk about instincts,
S.C. Sharma sir. Yeah. तो सर बोलते थे कि transport medicine is itself is a different medicine, and it is more difficult than critical care medicine.
Exactly.
So planning and preparation is very, very important for transport.
I would just like a quick word from Dhananjay sir, because he has been transporting and receiving neonates from across the Rajasthan.
Thank you, Dr. Gitesh, for giving me opportunity here. It's very rightly said, because transport medicine is totally different issue, because specifically in the neonates and pediatric age group, it's a very, very special, because during the transport we have to be connected to the referral as well as the referee doctors. So that requires tele connection like digital health. So we are doing for last 10 years. Though during this COVID era, it was a fortunate after this COVID era, because so many persons are taking care through the teleconsultation or telemedicine or digital health. So in my experience, so whatever we are doing, like just for an example, one patient, one called from periphery doctor, and preterm baby around 32 weeks having distress, sudden onset distress. So she called me कि सर ये बेबी को ट्रांसपोर्ट करना है. तो मैंने before transport we have to stabilize it, otherwise तो मुश्किल काम है. So for the stabilization, she was not able to understand what was the sudden onset of difficulty in breathing. So we organize this video call. So by video call and all investigations, so we just noted down that there is small pneumothorax was there. So we asked them just to put the needle ICD, but she was not able to put the ICD, but we asked to just put the needle only. So at least, and during this transport, we went well connected, and finally ICD put here, and baby was fine. So example, so for this instance, so many instances are there, so we have to be connected. This is ROI also for the particular in the private hospital, because you having a full network, academic network, a referral network. So you have to be given regularly support in terms of, it's not required that every time patient will refer here, but we should give them the support and confidence. Some basic critical care we can offer them through the telemedicine. So this is my ticket.
So, as sir has mentioned, and sir is one of the pioneers of telemedicine in Rajasthan. So, my next question to Dr. Shailesh, who is the director of Critical Care Hope, a tele-ICU provider in Rajasthan. Sir, how do you see the development of tele-ICU services in Rajasthan over the last decade, and especially pre and post-COVID comparison?
So, thank you, Gitesh. I think the biggest transformation that has happened is we were cornered in COVID. So, fortunately or unfortunately for COVID, we did not have any option. Otherwise, I think human tendency is not to change. Adoption was there, I think, and I think especially in the second wave when the huge surge was there. And as the sir said, I think a lot of patients were helped because of that. But the real issue is when you come back to real world of today. Okay, as Vivek said, transportation is the issue is, I think, critical care or medicine has gone through evolution. Why we do need post-critical care clinics is because we don't talk about survival. We are sure of some diseases, survival is improving. The data is there. Now it is quality of life. Okay. Secondly, why transportation is required is because by some means or something, we are becoming better at providing, let's say, a ECMO. Okay. So the reason I think tele-ICU is there is it is our fundamental duty to provide access to care now. The future belongs to not affordability. Affordability we are already working on. So why tele-ICU is required is, I think it is a fundamental duty to provide access to care at levels. Still, there is Red Health data which shows 41% of people across India die in the back of the ambulance. Around 80% of them did not need to be mobilized that time, okay, because of some reason or other. So our, I think, experience, when I say our is yours also and mine, limited. There are challenges. So there is a real world problem that we are solving with tele-ICU, which is improving access. We have to be fundamentally also honest with yourself. Are you helping everybody? You cannot help everybody. You need to know what you need to help. Third is, now I think Supreme Court guidelines has also come, which will help in future, is standardization of ICUs. We are not sure that, I think everywhere we need a level 3 ICU. That is the fundamental principle that we should not aim. Bharatpur cannot have a ICU of Jaipur, and that is wrong. The fourth biggest thing which I think is very, very important and which is very, very missing apart from access is critical care is not only about technical skills, it is about non-technical skills. We talk about communication. We talk about, Dr. Mani said about intuition. So those things, non-technical skills, communication, intuition, they cannot be taught. I think they are a learned skill. So by tele-ICU, when you are acting as a second set of eyes, you are actually providing those care providers those skills and those adaptability and time, so that over a time they become more capable. I think the only thing which we're a bit slow is, I think the fastest way to improve access to care is some regulation has to happen, which becomes mandatory for providing some form of care. And I think if government can make a move towards that, I think that is where the real that is where the real opportunity of tele-ICU lies.
And I think government is making efforts in the right direction, bringing up tele-ICU with PPP mode. So I think Dr. Vivek wants to add something to it.
I will first like to thank ISCCM. When I did this FNB course way back in 2010, we have very limited critical care people. If I talk about anesthesiologists, I am from anesthesia background. They are also told that they are very few as per the hospital standards are concerned. So if I talk about tele-ICU, I see a great boon in that. You are made available. My father-in-law is the gynecologist at Ratangad, which is a remote place. He told me about there are 3 basic things which are needed. A, B, and C again. We are always fortunate and happens to learn ABC. So that A means availability of the doctor. If a refined person is not the critical care in that village, a tele-ICU can bring it a lot of boon. That anesthesiologist can do whatever an intensivist can do in a procedure part as far as things are concerned. He can take the help of tele-ICU, the main brain behind everything. They can assess that. So for that, I think I should thank ISCCM, who has granted so many critical care people, who have affiliated so many institutes, and thanks.
Yeah. So moving forward, now we come on to, as we are discussing ICU beyond walls, so we come out of the hospital environment and we go to ICU at home. So I would like to ask Dr. Sunil about his experience over the last decade and how is it different to practice critical care at home. I definitely know that it is more challenging than practicing critical care in ICU. What is your experience, sir?
So basically this was a boon for me that I was an intensivist. I am an intensivist. So I started Simon Healthcare around 4 years back, and as soon as I started there was a surge of COVID. So if I counted COVID patients altogether, I treated more than 6,000 plus patients at home. So the basic challenge, if you talk about, I am talking about extended ICU care at home. So first I'll talk about everybody asked me about the legal or like what are the guidelines, can we treat at home or not. So truly speaking, it's a gray area. And if we talk about simple clinical establishment license, which actually hold the center. The rule came into 2010, but we talk about Delhi Health Bill came into 2019. So if you are having a clinical establishment act, which means prevention, diagnosis and treatment of clinic. But here we are treating patient at home, so probably it will work or not, we do not know, number one. Number two, ISCCM has laid some guidelines for opening ICU at hospitals. So if we are following almost same guidelines at home regarding quality and availability of equipments, like I am providing a cardiac monitor to the patients, but that monitor is not working, that syringe pump is not working, that is waste. So a good quality, good availability of equipment, oxygen cylinders, everything should be there. Number three, informed consent from the patient family, along with scope and limitations of your extended ICU care at home with plan of escalation and transfer to the hospital. Number five, we talk about the robust, you can say, auditing system. So auditing is very, very necessary. And if you can take some accreditations which actually doesn't valid and are not existing in India. So we are trying with NABH. I talked to Dr. V.K. Rao also to implement some guidelines for extended ICU care at home, and probably we are working on that. We will come out for some guidelines. Main challenge is human care or the manpower. The trained critical care nurses are not available, and if available, they are alone or maximum 2 nurses at a time. If you talk about a hospital, a 12-bedded ICU, one patient gets sick, all 12 nurses or 11 or 10 nurses comes on that bed for the help. So the planning is very, very important. So over the period of 4 years, we have reached to that stage that even we have provided extended care at home without any litigations, without any complications at home. So we keep certain amount of emergency medicines at home, certain amounts of consumables. We assume a patient's that the planning of patient is very, very important. We make a blueprint and we keep all emergency medicines at home, whether it's required or not. We keep all emergency equipments at home, ambulance availability and everything. And we made basically Android and iOS app, totally digitalize it. The nurses putting each and every data on their mobile phones. We have made a command center where the doctor are 24/7. So our availability is 24/7. So these are the challenges which were very much what we, truly speaking, we have overcome now most of the challenges.
Right. So what I understand is one thing is you need a lot of data technology. The other thing is trained manpower at the bedside. and then patient faith, consent, documentation, and the last, you have to know the limitations of extended ICU at home and plan accordingly.
For manpower, we have started currently just around few days back, good training center. So now we are providing our all nurses accommodation with food, with health insurance, and whenever they are free, the on-site and off-site training. So we have appointed a critical care doctor for their training.
That's good. Dr. Vivek, your comments, please.
Yes, yes. I have opened this concept when my mom itself got sick when I was working with Eternal. So that time we have faced challenge that she doesn't want to go to the hospital. So that time is the first time when I realized if I don't develop a parallel system, I will not be able to help her in future. And it's the past 10 years, I've been doing this healthcare at home. It's my baby concept, which I started way back in 2016. And I totally agree with Sunil boss regarding the various aspects that he discussed. The key important one more area that need to be emphasized is the biomedical waste that need to be deported from the patient side to the hospital or some area like instrumentics in Jaipur, which is the biggest challenge. If you dump it in that is again a very good challenge, and logistic, healthcare, consent forms, and availability of a doctor. By means of, if I look at the preview of Dr. Sunil, he is telemedicine, he is again using a telemedicine, he is available round the clock to assist their nurses at the bedside. Whereas on the contrary, in my setup, what I am doing is I am taking only 2 patients at a time, and I regularly visit twice a day to that place. So that is a great boon, and what we have just discussed in the previous session.
Vivek has basically raised a very good point. So for the biomedical waste, we have now started sending a sharp container, and we are collecting that container whenever this gets filled. Regarding biomedical waste, we tried a lot, but that was a very costly thing. So when we talked to the biomedical waste person, he said that if you are running 100 patients all together, I need biomedical waste at a single point. Then you have to run a lot of basically vans to collect that biomedical waste, to bring to your own center, then to disperse it. So it's definitely required, but truly speaking, we are not doing it.
Okay. So moving on to the last leg of the discussion. So as we have seen that the practice of critical care has evolved, and so our fellow intensivist has also evolved. You are seeing on the dais people who are entrepreneurs, who are senior in the hospital management. So I would like to ask Dr. Shailesh, who is a ISB and Stanford alumnus, so what are the qualities an intensivist is blessed with as by nature of his job, and what are the qualities you need to develop to become a leader in healthcare ecosystem?
So I think, I don't know, but it is by default or it is a setting. I think a lot of intensive care people are from anesthesia background, right? Okay. 90%. So basically हमारे में survival instinct OTC आ जाता है. तो एक problem तो वहीं खत्म हो जाती है leadership की. We know how to survive. If you can survive in your first year residency working with a very senior orthopedic consultant, I learnt my way how to survive in OT. So I think leadership is also about survival in difficult times, I think. So why intensivists are good? One is, I think we see our seniors running, managing theaters, managing complex situations. The surgeons start believing in there is this trust. So leadership has 2 or 3 things which are very, very important. First, I think you need to gain trust of people. Okay. Obviously, there has to be passion and there has to be skill in everything. Second thing I think which is very, very important is early adoption of a lot of things. So we are inherently, we are a bit of risk takers. So you can actually say home care mein ye nahi kaam karta, ya transportation mein ye nahi kaam karta. But in a country like India, if you don't do home care, if you don't do transportation, if you don't treat sick babies on a telephonic advice, do you think the system will run? I don't think so. And thirdly, early adoption, we took simulation, we took ECMO, we took, you take anything, newer drugs, newer therapies, newer areas, going outside of critical care. So I think personally feeling, not that I'm an intensivist, though I'm anesthetist at training, I think trust, I think the ability to take risks, calculated risks. And I think the third thing is that the survival instinct. I think that makes a good combination for critical care doctors to become part of the. Thirdly, which I think helped me in terms of my training and then working in a family business, I think we need to know a lot of things which I think management does, and I think from a doctor aspect that is very respectable. I think we know about equipment, we know about drugs, we know about challenging situations, we know about crisis management, we know about emergencies, we are good at bed management, we are good at people management, because two conflicts in theater, two different opinions, and so I think why I propose, I think all of us should do some form of management. I think because that is where healthcare needs more doctors as managers rather than managers as doctors.
Just a quick comment from Dhananjay sir, who is a hospital owner, and how difficult it has become in the present scenario, especially in Rajasthan with all these schemes. So should somebody think of it doing?
Yeah,
care on?
very rightly said. Because doctors must be initially manager once manager capacity comes after clinical experience. So first we started the clinic, then small hospital, big hospital, and then after big hospital we engage so many critical intensivists. Then you think then we have to smoothen the work and just to not only quality of care as well as just to save ourselves through a legality also. So for that, the experience, practical experience, clinical experience, and after that management comes by experience only, because after doing this my 30 year of practice, so what I learned, so it last 5-6 year I am in the management also and the critical care also, but management comes only जब हम जाते हैं क्रिटिकल केयर कोई कर रहा होता है तो वहाँ पे ये कि बस इसमें ये प्रॉब्लम्स आ रही है तो वी कैन अंडरस्टैंड. अदरवाइज तो मैनेजमेंट जो पहले से एक कि आपने कितने भी हायर कर लो क्लिनिक हेल्थ केयर मैनेजमेंट, जब तक खुद डॉक्टर जो प्रैक्टिकल एक्सपीरियंस करके आए तब तक उसको नहीं होता. सो माई एक्सपीरियंस, वी हैव टू हैव अ क्लिनिकल एक्सपीरियंस एंड we have to train our staff as well as our colleagues to take care of the management also.
I think any comments from any other panel include the discussion.
Yes, in post-COVID era, COVID act as a catalyst to break the ice and acceptance of the not only community but also in physician fraternity about the online consultations. We are doing regularly Zoom meetings and access to legendary personality in your online platform. That is very common. So yes, ब्लेसिंग विद डिस्कस वाला हिसाब है कि इसकी एक्सेप्टेंस आई है. उसी के बाद में ये टेलीमेडिसिन एंड ये एक्सटेंडेड आईसीयू केयर, इसका कॉन्सेप्ट बढ़ा है.
So thank you all for your patient listening. Any comments or questions from the audience are welcome. I think Dr. Akhilesh.
And in my personal opinion, we have to be always open and adaptive by all recent technology that I had heard last. So we should not having some like करना नहीं है, हमेशा करना है, हमेशा we have to, we are a really scientist to adapt the multiple technology, but definitely all our boons and bans is there. So you are always open to take the technology.
Dr. Akhilesh, you're not audible. Please switch on the mic.
Thank you, Dr. Gitesh, and all the panelists for their meaningful insight in this area. I just have a quick question about telemedicine and its medico-legal implications and especially the counseling. So I'm just assuming that suppose it's a different town where you have a tele-ICU. So there can be two options. I mean, either the nurse is seeing the patient and we don't have a doctor, or maybe we have a resident doctor, not the intensivist there. In that case, so when a patient is admitted in such setup, either we explain them that there is an advantage that we will be having a doctor on phone or on camera, and what is the way those patients and relatives are counseled, and if a situation arises that the patient's condition deteriorates. So as we see in a one-to-one conversation in our ICUs, whenever a situation goes wrong, doctors are to blame. So when you face such situations in those tele ICUs, I mean, how do you communicate again?
Yeah. So
and its medico-legal implications,
I know.
whatever is happening.
So there is the telemedicine practice guideline (TPG) guidelines before 21 and after 22. So basically, there is a openly and that they have written the TPG guidelines legality. So many limitations, so many things are being explained, though there is a gray area, but just to prevent yourself from the legality, you have to go through the TPG. So government NMC already asked for the 3-month course for the TPG before starting the telemedicine consultation. And practically we have to give telemedicine consultation to the B2B like doctor or nurse, those who are providing the local setup, not directly patient. Or if you are taking it just mobile se jo lete hain na consultation, so that is the explicit consultation, but always in explicit consultation there is a disclaimer that anytime you can show your local doctor also.
Okay, so if a situation,
can I add on to that, Akhilesh? So as a sir said, that it's always B2B. So what we do, I practically, so there is many, so from 2019 there have been guidelines, whether it's 100% solving the issue, whether it will 100% ever solve the issue, I don't even know yet, okay. So I think we have a physician or a surgeon or a, let's say, a neurosurgeon, because in our case we are, who is primarily responsible for care, okay. So the patient is admitted under his care and we are basically a second set of eyes, okay. Secondly, when we publish something or the paper goes medico-legally, we are advising that to our guidelines to that person who can use that. So we don't expect him to use 100% of our intelligence on the ground. He has to make a decision. So that is how basically we even publish what we publish every day for patients is an advisory, okay. So whether it solves the purpose, yes, some people utilize it. Okay, 100% adoption of whatever we publish is never there, and we do not expect that whatever we say is going to be adopted 100% there.
And just to add on to that, my experience, it is important to publish, it is important to document, but if you want your colleague who is sitting in the other city to follow it, it is very important to communicate with him over phone, explain your perspective. If he understands your perspective, your point of view, the chances of him of implementing that advice increases over a period of time.
So
that's very important.
What I understand by this is there is no direct communication of the telemedicine ICU physician with the relative. It's totally the responsibility
if it's
of the
required.
primary
If the primary doctor asks for it, you can do it. We do it.
What I totally understand, I agree with both my panelists and Gitesh also. So there are two type of consultation which people usually ask. One is the doctor at a hospital requires some help and he has called his associated tele-consultation consultant. The second is the patient relative want a second opinion. He cannot come to a tertiary care center. So he also fetch out all the investigation and a short summary, and then he try to communicate with the consultant sitting at a tertiary center. So both the sets are different. Both need a separate documentation process and a legality also. And this is totally a gray area, as Dr. Shailesh has correctly pointed out.
Yeah. Thank you.
And it is an advisory which may or may not be relevant. He can pick out whatever is relevant to him. Thank you.
Thank you. So I think we have already exceeded the time. With this, I thank all the panelists for their insights and meaningful discussion. So with this, we conclude this discussion. Thank you all for your patient listening.
I thank you, our esteemed panelist and moderator, for broadening our knowledge with such an intuitive discussion. I request them to collect their mementos from Memento Station outside Hall A. Moving on, a warm afternoon, everyone. Marching ahead, I, Dr. Shubham Jain, alongside with my co-host, Dr. Meenal Pava, will be taking you through our next session of Respiratory Critical Care Medicine.
Respiratory critical care are subject of utmost importance in our field. Each breath we take fuel life itself. Understanding the complex dynamics of the lung and airway is quintessential for management of all the critically ill. Now I would like to invite our esteemed chairpersons for panel discussion on difficult to wean patient.
Dr. R.K. Singhvi sir, HOD Emergency Medicine, SGPGI, Lucknow. Dr. Kapil Dev Chhabra sir, Senior Consultant and HOD Critical Care Medicine, Maharaja Agrasen Hospital, New Delhi. Dr. Sunil Kumar Garg sir, Senior Critical Care Physician, Co-founder and CEO of Simon Healthcare, New Delhi. Dr. Rakesh Modi sir, Professor, Department of Critical Care Medicine, NIMS Hospital, Jaipur. And Dr. Sanjay Sanghvi sir, Senior Consultant, Pulmonology, SDM at Jaipur. Now I'd like to invite presenter on stage, Dr. Nitin Sharma sir, Consultant Critical Care Medicine from EHCC, Jaipur.
A very warm good afternoon to everyone and panelists. I am Dr. Nitin Kumar Sharma, Consultant Critical Care Medicine, ESCC Jaipur. I thank you so much for the Jaipur Criticon 2025 team for giving me a wonderful opportunity to present a case on difficult weaning in a patient with COPD and pulmonary embolism. I warmly welcome to my esteemed panelists, and I invite them to share their expert insight on this particular topic. Dr. R.K. Singh sir is not available with us because of some personal reasons, so we'll continue. So our patient was a 64-year-old male patient. He was a chronic smoker with a history of 40 pack years. He's a known case of COPD, gold classification stage 3. He was on domiciliary BiPAP support. He was hypertensive with no any known prior thromboembolic events. As he presented to ER with acute worsening dyspnea, cough and purulent sputum for last 3 days. On examination, he was having sinus tachycardia. His BP was 100 by 60 millimeter of mercury. He was tachypneic. He was desaturating on room air with the SpO2 of 74%. He was using accessory muscles. He was in altered sensorium. JVP was mildly raised with mild pedal edema. Chest X-ray showed diminished breath sound with occasional wheeze. The immediately ABG was done, which showed acidic pH of 7.2 with PaCO2 of 78 millimeter of mercury. PaO2 is 52, bicar was 32, and lactates were 3.2, which was suggestive of chronic retention with acute exacerbation. So NIV was initiated as first line ventilatory assistance. Meanwhile, 2D echo findings showed normal RA-RV with mild PAH with RVSP of 36 millimeter of mercury, mild TR, IVC was dilated with normal LVEF. After 2 hours of NIV support, a repeat evaluation of ABG was done, which showed worsening of acidosis with persistent hypoxemia, signs of respiratory fatigue with worsening sensorium of the patient. So a decision of elective intubation was taken and the patient was started on invasive mechanical ventilation. Ventilation strategy was optimized to low tidal volume, respiratory rate around 12 to 14 per minute with high I ratio, optimal P, and controlled FiO2 to target SpO2 of between 88 to 92%. He was treated with IV steroids in the ICU, nebulized bronchodilators, empirical antibiotics, and bronchoscopy was done once to clear secretions and to take infection samplings. Over next 3 days, the patient responded clinically. He became hemodynamically stable, febrile, awake, and he was following commands. The secretions was manageable. He was producing effective cough. Subsequent ABG was normalized. pH was 3.7, PaCO2 was 52, PaO2 was 88 with bicarb of 30, on FiO2 35%. He was maintaining saturation of 92%. There was no signs of autopeep. He was maintaining even fluid balance. Hemoglobin was optimum 11.2 with normal electrolytes. and so sedation was tapered. So here I want to ask my first question to Mr. Modi sir. Sir, what is weaning from the mechanical ventilatory support, and how do we define the weaning is successful or there is a failure of weaning definition?
Good afternoon and thank you for taking this topic, because we see weaning is always challenging for treating team as well as patient. And we see it in day to day that most of the time 40 to 50% of the patient during his ventilator journey spent on weaning. So weaning is, when we say what is the weaning is simply a process we need to take in steps, like liberation from the mechanical ventilation.
Exactly, sir.
How do you separate the patient? So it is a transition of work of breathing from ventilator to patient. So this is a physiological aspect of weaning. And when we say weaning, so first we liberate the patient from mechanical ventilation by different method. And another thing is to extubate him, to remove the artificial airway, either endotracheal tube or tracheostomy tube. So when we say we can categorize the patient, like some patients are easily weanable, we give SBT and we can extubate him. Some patients are, their respiratory pump is okay, we can separate them from the ventilator, but we are not able to extubate them, we are not able to remove the artificial airway. So somehow these patients, because of central nervous system issues, because of upper airway issues, because of neuromuscular disease, because of any metabolic issues, so we can say these patients are weaned off, but they are not extubatable.
Exactly.
And some patients, they are doing okay, but they are requiring some form of respiratory support post-extubation.
Yes,
so we say this is a weaning is still going on, but patient is able to handle their airway, patient is able to cough out the secretion, patient is able to take orally, but they are still, the weaning is still going on.
Yes.
So when we talk about weaning success, so weaning basically when you extubate and wean the patient from ventilator and extubate, and patient is not requiring any kind of respiratory support in following days, for 48 hours at least.
Okay, sir.
And patient is doing okay. When we say weaning failure, you do your screening test like SBT and patient fail. Then we need to see what is the cause, multidisciplinary your assessment. And this is the first weaning failure. Second, patient passed your SBT, but in next 48 hours, patient require either again reintubation and invasive ventilatory support because of some respiratory issues, then this is also called a weaning failure. And either patient die within next 48 hours due to some, then we also call this a weaning failure.
That also come in the definition part of the
Yes,
weaning
weaning
failure, sir. So after knowing about the definition part, my next question to the panelist, Dr. Kapil Chabra sir, that sir, is this patient is ready to be weaned from mechanical ventilation support, and how do we perform an SBT to this patient?
I believe yes, this patient is absolutely ready for the weaning process. The first and foremost thing that he is improving from his original primary medical problem because of which he got intubated.
Yes,
so
sir.
he is coming out of it.
Yes.
His pH is maintained, he is triggering his respiration, his PF ratio is good,
Exactly.
and his carbon dioxide levels are improving. So all his respiratory parameters, oxygenation, carbon dioxide, pH is improving, baseline, his disease is improving, he's triggering the respiration, and other vital parameters you explained, hemoglobin, electrolytes, everything is fine, hemodynamically stable. Yes, he is ready to go for winning trial.
Okay, sir.
And to perform spontaneous breathing trial, traditionally three aspects are available. One is TPS trial, pressure support ventilation trial, and SMV trial. SMV trial has not been shown to be up to mark for spontaneous breathing trial because it delays it. So either you can go for TPS trial or pressure support ventilation trial with a minimum pressure support that just supports the resistance of endotracheal tube.
Yes, sir.
So here in our institute we prefer pressure support over TPS trial, and we give it for 30 to 120 minutes depending on clinician's choice. I personally go for 30 minutes pressure support ventilation trial.
Okay, sir. So, after understanding about the spontaneous breathing trial, we move forward to our next question that, sir, how do we one second, sorry. Level. So after failed 2 consecutive SBTs, he was having good sensorium. He had clear chest with no crackles and or signs of infection. He had normal electrolytes or minimal sedation. So, sir, my next question to our panelist, that how do we assess the winning failure, sir? How do we assess winning failure? And I would like to ask this question to Dr. Sunil Garg, sir. The major contributing factors of winning failure, sir.
First is how to assess winning failure. So there are a lot of things basically, but I will say we should use personalized medicines. So one is a rapid shallow breathing index, in which we see the frequency, the respiratory rate divided by tidal volume. If it is less than 105, the patient is having a good weaning basically. And another criteria is clinical criteria, like to look at the patient, whether patient is becoming tachypneic, hypertensive, is going into altered mental status, or the ABG is worsening. I'll say there was a score basically, which was a HACOI score, which was actually predictor of NIV failure. But I'll say we can use that score here also, because heart rate increases when weaning fails, acidosis, you say the conscious level can deteriorate, and the oxygenation can deteriorate, and the respiratory rate can increase. So you can use this score as a clinical score also. So basically, I'll say that we should combine all of these together, because none of the proven get to be proven complete method of weaning success or failure.
Okay, sir.
And contributing factors for weaning failure, you can start from CNS to toe. Number one is neurological. So just to remember, I am not saying that this is a number one. So neurologically, patient is over sedated or patient is in delirium, the weaning trial can get failed. Number two, coming on respiratory system, a patient is COPD patients, look at the respiratory, basically a respiratory physiology. The patient can have bronchospasm, secretions, or some other pathology like pleural effusion or anything else. Number three, look at the cardiovascular system. In cardiovascular system, a patient with good ejection fraction can have weaning failure. We recently encountered a patient which we have shifted to home. I can present. I have 2-3 slides. So these patients can have basically heart failure with preserved ejection fractions, and they actually get failed weaning. Number four, coming on the nutritional status. A patient whose muscles are weak, the very poor nutritional status, will have difficulty in weaning. You go outside, that means the critical illness polyneuropathy, including diaphragm weakness, and all others like electrolyte imbalance, hypophosphatemia, hypomagnesemia, hypokalemia, even low hemoglobin level can cause weaning failure.
Exactly.
So these are the certain factors which can cause weaning failure.
Really great, sir. So these were the important causes from weaning failure as sir.
I want
Yes,
to
sir.
add, most of the time regarding cardiac failure, most of the time our focus remain on left side of the heart. What is systolic ejection fraction?
Very
Most
important,
of the
sir.
time. And the person who is coming for 2D echo, and there is a possibility that patient, this patient you can identify very easily. They already having history of CAD or 25 to 30, 40% ejection, but Dr. Sunil said, identifying those patients who are having preserved ejection fraction with diastolic dysfunction, it is very difficult because at the time he is doing 2D echo, there is a possibility type 1, type 2 diastolic dysfunction, he may not be appreciate, or there is always an inter-observer difference. So, and along with that, you should always focus on right heart of the function simultaneously to see the right heart function, IVC right heart function also. And sometimes doing simple things can do magic. Suppose during SBD trial, if patient is developing hypertension and tachycardia, but patient is not having any cardiac history. So just controlling them, controlling blood pressure and heart rate, you may be able to, yes, you may be able to win few patients among those.
Very truly said. So after understanding different causes of winning failure, here I will go for the systematic approach, and I asked Mr. Sanjay Sogani sir about the respiratory system. Sir, mechanism behind respiratory causes of winning failure, and when can we suspect respiratory causes, and how we can diagnose and treatment in brief, sir.
Yes. If respiratory system could not fulfill the demand of spontaneous breathing trial, it's lead to the winning failure. There's a various causes of respiratory system which lead to the winning failure. Those factor increase the respiratory load, and those factor which are decrease respiratory capacity. Those factors which are increase the respiratory load, such as I think bronchospasm, tracheal obstruction, endotracheal tube, secretions in the airway, and other airway disorders, not parenchymal disorders. These are increase the respiratory system workload. Now, decrease respiratory capacity. Respiratory capacity decrease in where there is a weakness in the respiratory muscles or diaphragm, or also critical illness, neuropathy, myopathy, some metabolic disorders like hypothyroidism, and some electrolyte imbalance like hypokalemia, hypomagnesemia, hypophosphatemia. These lead to the winning failure.
Yes.
When to suspect? We suspect winning failure when the respiratory, increased respiratory effort or oxygen failure. Oxygen failure by like decrease SpO2 or increase PCO2. So which when to suspect the winning failure. Like we examine the patient, look for bilateral bronchospasm. And also we rapid shallow breathing index if increase, we also lead to the respiratory muscles weakness. And also where the patient is tachypnea, tachycardia, diaphoresis, so this will lead to the, which are due to the high respiratory load. So these are the some indications when we can diagnose the winning failure. How to diagnose? So some, I think some chest X-ray, sonography, and also examination, we can diagnose the these respiratory system cause of winning failure, and treatment according to the diagnosis.
Exactly, sir. Thank you so much, sir. Moving towards the cardiac causes of winning failure, I would like to ask Dr. Sunil Garg, sir, how does cardiac dysfunctions leads to winning failure, and how can we diagnose that? Sir, you can add your case also quickly, which you recently encountered, sir.
Okay.
So basically, we had a patient who was 82-year-old, was a COPD patient, CAD, post PTCA, severe aortic stenosis, post TAVR in 2018. So he was admitted to basically one of the corporate hospital at Delhi with complaint of drowsiness, and he was found to be hypoglycemic. The blood sugar was 30, and he was having altered sensorium. The AVG was having respiratory acidosis, so he got intubated basically. So after the intubation, so patient was hypoglycemic, type 2 respiratory failure, intubated in the ER and further managed in ICU with NORAD, antibiotics and other supportive measures. Weaning attempted but failed. So PCT was done on 27th of August. He was admitted 21st of August. So in 7 days, basically PCT was done in view of anticipated prolonged mechanical ventilation. So what all issues the patient? Age, 82 years, CAD, post-PTCA, in fact aortic stenosis, post-TAVR, COPD, long COPD, so anticipated prolonged mechanical ventilation. So we have already discussed like all parameters what patient was having. Number one is respiratory mechanics. Like he was a COPD patient, so probably respiratory mechanics is not as normal as we expect from a normal patient. Respiratory muscle dysfunctions because he was on ventilator at 82 years of age. COPD patients has exposed to a lot of steroids and antibiotics in the past also, including diaphragmatic weakness. And third was nutritional. We thought only 3 issues altogether, and the weaning trial was attempted after doing, but was difficult to wean from ventilator, so shifted to home on 13th of September. So after 20 days of hospital admission, he was transferred to our care. So at home, we attempted smaller weaning trials after corrections of respiratory mechanics and nutrition, which we were supposed to be the cause of weaning failure, but we also get failed. So we thought of cardiac dysfunction in view of previous history of CAD, PTCA, despite of having normal EF, as Dr. Rakesh Modi was saying. So here the EF was normal, but we thought of having cardiac failure with preserved ejection fractions, right? So we sent anti-proBNP and it came out to be 20,470. So we started on furosemide with GTN, and weaning trial was attempted again, and we reached to continuous weaning trial of 80 hours, and it is still on. So basically in 20 days we reached to 11 hours just looking at the cardiac functions. I want to show you some videos of this patient. This is VJ1. So on day 1, we attempted the weaning trial, and you look at the patient respiration. The respiration is not good basically. So this trial got failed actually on day 1. Then we started basically worked on nutrition and rehabilitations. So very good physiotherapy and rehabilitation was started at home. Patient is moving his own limbs now. This is the physiotherapy which our therapist is doing at home, and this is the beauty of home care, that the physiotherapist can give almost 1 hour. In hospital, I think in 1 hour physiotherapist can see almost 10 patients all together. And now look at the strength of the patient. Like patient is standing even at least with support. Okay. Here patient is basically cycling. So we keep a small cyclic at home. So basically this improves patient calf, basically quad muscles, quads and hamstrings. And then we started doing weaning again. And now look at the patient. The weaning, he is quite comfortable. So we started from 15 minutes weaning and 2 hours on. Then we reached to 30 minutes, then 1 hour, 2 hours. Now we are at 11 hours. So patient is without ventilator for 11 hours. Then we connect ventilator for 1 or 2 hours. Then again we put for 11 hours. This is still going on. So one of the example.
Any available CT scan of this patient?
अभी तो नहीं मिलेगा मेरे पास, but I'll show you.
Because sometimes expiration dynamic airway collapse in prolonged ventilation lead to the weaning failure. Because of, due to the muscles of the trachea weakened due to the, I think, in COPD patient due to the long-term steroids, or sometimes pilot blood also inflate the, lead to the necrosis. So sometimes airway collapse also lead to the difficult
This
in weaning.
patient was intubated only for 6 days. On 21 he was intubated, 27 PCT was done.
Just a quick comment here, Sunil was. We published a paper just recently in ESICM VIPO trial. That was weaning induced pulmonary edema. This was with France, Italy and our Indian ICU. And we had analyzed 500 patients regarding this weaning induced pulmonary edema. And we found that 36% patients of all weaning failures are because of this cardiac dysfunction.
Yes.
And the two most important factors are, one is definitely cardiac dysfunction and second is COPD. So your patient had COPD as well.
COPD along with cardiac failure.
Both were there. So the chances of weaning failure because of VIPO was very, very high in this patient. So as our trial has already shown it.
Third point I want to add on basically, like what happened in the hospitals, because we are engaged with so many patients and this is very much routine. So usually when we start weaning in the hospital, we start from 5-6 hours in a single go. And then patient get fatigue actually. At home we start from only 15 minutes weaning. Even if patient doesn't get tired, we connect on the ventilator. The next day we increase it to 25 minutes or 20 minutes. So this actually improves the chances of weaning from the ventilator.
A small comment, like weaning induced pulmonary edema, you send anti-pro-BNP and it was very high. So sometime doing anti-pro-BNP again and again is become a costly affair, particularly the who are working in a low resource ICU costly. So you can do another thing, you can just take a sample, do hematocrit before you start SBD trial, and whenever the patient fail, weaning trial, do again hematocrit. If it is the difference is hematocrit rise more than 5 to 6%, then you can also label it as a weaning induced pulmonary edema. Okay. So it is, this test is very simple and having very high specificity, more than 90%. So in doing anti-pro-PNP, if you have a facility, it's good. If you don't have, and it is taking time. Sometimes you are sending anti-pro-PNP, the report is coming after 12 hours. It's not useful. So you can do a bedside test.
To make a diagnosis and to cut the duration of mechanical ventilation, it is not costly. Because if you can cut down the duration of ventilation by 10 days or 7 days, the cost of anti-pro-PNP is not more than 1500 rupees.
You are very correct. But sometimes the test is not available in your facility. Yeah. When you can do this simple test.
Thank you so much, Sunil sir and Kishore sir, for adding some valuable inputs. So, moving on to neuromuscular causes, sir, I want to ask Dr. Kapil sir, what are the neuromuscular causes of weaning failure and what are the role of USG in diagnosis ventilator-induced diaphragmatic dysfunction?
See, out of all the causes which we have already discussed, when we talk about the respiratory capacity, which is in imbalance with the respiratory load of the patient because of disease, the respiratory capacity of the patient is low because of this neuromuscular problem, critical illness neuropathy, critical illness myopathy, and the whole maximum brunt is faced by diaphragmatic muscles during intubation and further progression of ventilatory days. This is because of lot of stress, cytokines, drugs, hyperglycemia, steroids, all combined, the maximum toll is paid by respiratory muscle in the form of diaphragmatic dysfunction. And while doing weaning assessment of the patient, assessment of weaning trial, ultrasound definitely plays a big role to assess the diaphragmatic function, and we really do that diaphragmatic thickness fraction, which is the best test I see, and I see it as equivalent to your RSBI test. And if the diaphragmatic thickness fraction is not increasing in inspiration by more than 30%, we take it as there could be a weaning failure in such patients. And there is another role of diaphragmatic excursion also, which I feel is not very sensitive test, but if diaphragmatic excursion is more than 15 millimeters, we take it as a weaning success. But diaphragmatic thickness fraction, I do rely on that.
That's really great,
Yeah.
sir. So we have already discussed so many causes of weaning failure. Now moving quickly towards our last two questions. Sir, what are the different modes of ventilation preferred in difficult weaning? The conventional ones and the newer modes. Dr. Kapil Sabda, sir.
So the conventional ones we have already discussed. It's a TPS trial versus pressure support ventilation trial versus SMV trial. SMV is the worst out of all, and pressure support I feel is the best. That gives a safety to the patient as well, and gives a very accurate dynamics of the lung in the form of accurate tidal volume, how much the patient is inhaling, respiratory rate, RSBI you can calculate very easily. So pressure support I feel is the best in conventional.
Exactly,
one.
the study shows the same, sir.
So another thing is newer mode, proportional assist ventilator, ventilation, adaptive support ventilation, NAVA ventilation, and many other these AI generated softwares where ventilator helps the patient to get weaned. Truly speaking, these newer ventilator modes have not got that much popularity and that much confidence of a clinician, but yes, some studies show that they reduce the weaning time. But exactly outcome benefits are not there. I mean, outcome in the form of mortality benefit or ICU length of stay or hospital stay, or they just help you doing a weaning a bit earlier. But then, as I said, we do not have much confidence on that as of now. Yeah.
The sample size was really small with studied for the NAVA.
Yes.
Yes, sir.
Yeah.
So my last question to Dr. Sunil sir again. Sir, what is the role of tracheostomy in this patient? Should we go for early tracheostomy or the late tracheostomy for these kind of patients?
Dr. Modi was actually telling one thing in the beginning, that the one is the weaning, liberation from mechanical ventilation, and another is extubation. So please do not correlate both the things together. Weaning does not mean you are able to extubate your patients. Right? The same with tracheostomy patients. If you have weaned your patient while he was on or she was on tracheostomy, you are able to decannulate or not is a different question. Okay? So try to understand your patient. Okay? Early tracheostomy means you are, number one, anticipating prolonged mechanical ventilation. Do tracheostomy on day one, I say. Even do not wait for 3, 4, 5 days. Number two, if your ventilator trial is getting failed and patient got reintubated within 48 hours, I think go for tracheostomy rather than taking another trial of weaning from ventilator. So my idea for tracheostomy is basically, I'll give you one example. One basically a hefty boy of around 15 years was in one ICU of Delhi, and he had pneumonia, was intubated on ventilator. The weaning was done on expense of NIV. How many hours? 23 hours in a day, NIV. Now you talk about, can you do rehabilitation of that patient? Number one, can you do the RT feeding of that patient without any risk of aspiration? So why not to do tracheostomy in that patient? That case came to me after staying of 25 days in ICU. I asked the pediatrician to do a tracheostomy. वो मेरे ऊपर गुस्सा हो गया कि यार हम तो यहाँ चला रहे हैं 25 दिन से, तुमको ट्रकियोस्मी की ज़रूरत पड़ेगी, मैं नहीं करता ट्रकियोस्मी. फैमिली को समझवाया, किसी दूसरे मोड से समझाया, जाके उसने ट्रकियोस्मी करके दे दिया. Day one we brought the patient at home with ventilation. Gradually we weaned off from ventilator. There was lot of trauma on the forehead. The nasal bridge was completely broken down. The oral cavity was having lot of muck. So we did a good rehabilitation, good nutrition, and patient got decannulated after 1 month. So in my view, early tracheostomy is the answer. Just review your patients, means do the personalized, because if you are looking at the patient, you can judge whether this patient requires tracheostomy or not. Don't give unnecessary basically extubation and reintubation. एक केस मैंने और बनाया था छोटा सा, पर टाइम नहीं है अभी. मतलब जैसे एक पेशेंट को फ्रैक्चर हुआ D4 D5, पेशेंट फॉल फ्रॉम हाइट 3rd फ्लोर, Now the patient fracture got stabilized by screw from D2 to D6. Patient was intubated, shifted to ICU. Now in ICU, what do you think? Patient is having paraplegia, right upper limb power is 2/5, and patient is having cord edema. Would you really able to extubate this patient?
Not really, sir.
But extubation was done, and extubation was failed. Within 12 hours, patient got reintubated. But before that, he has aspiration. Patient was started on NORAD, antibiotics, then PCT was done, and on discharge summary, this was written. This PCT was done because of anticipated prolonged mechanical ventilation, which was while the patient was in OT. So now we brought that patient at home, and gradually we are doing weaning, and we reached up to only 30 minutes weaning attempts. So tracheostomy should be considered early.
Yes, sir.
I would like to just give my feedback, like working in ICU. I would rather say that it is an individualized decision based on patient parameters. So I usually divide such kind of patient into categories. One is medical or surgical patients. Another is neuro patients, like whether it is a neuromedicine or neurosurgical patients, because they behave entirely differently. Neurotrauma patients, for example. So neuro patients, definitely in anticipated difficult extubation, in anticipated prolonged ventilation, we go for early tracheostomy. But in medical patients, we have a little bit of reservation. And in medical patients, for example, ARDS, this patient might get extubated after 10 days. Still, we go on with the patient endotracheal tube and all. So if I take it broadly, just the timing, I would say in medical patients, I would be around 7-10 days, I would take a decision, but in neurosurgical patient, I can take an early decision because of anticipated.
So decision of tracheostomy should be made on the clinical
yes, it has to be individualized.
Definitely, sir. So just to conclude, as we are limiting out of the time, so whenever we see an intubated patient, we have to daily screen the patient to assess the readiness to wean. We have to go make examination for potential reversible pathologies, and after reversing that, we have to go for the spontaneous breathing trial. If we suspect or find any reasons for difficult and prolonged weaning, we have to think for respiratory, cardiac and neuromuscular, all the causes we have already discussed. We have to find out the specific risk factor for difficult weaning and quickly diagnose them. We should determine the cause and start the treatment. And again, we have to give spontaneous breathing trial to wean the patient. So here I end the discussion. Thank you so much, sir, for your valuable inputs and expert insights, sir. Thank you so much, sir. Any question? Yes. Ma'am, your voice is not audible once.
The case you mentioned, that the patient who was difficult to wean because his anti-pro-BNP was too high and you suspected there's some preserved EF, but there was a failure. So weaning such patients, do we ever think of giving any support to heart while weaning so that the weaning can become more easy? Have you ever tried that?
Support to heart means I didn't get you.
So suppose mostly these COPD patients are in RAR, like right-sided failure.
Yes.
This we all see. So if we support right side of the heart by any low dose inodrop during ICU stay, will it be beneficial to wean the patient?
Basically here the issue is the patient is overloaded. There is a more cardiac stretching and patient is in failure. That is right ventricular or left ventricular failure.
Yeah,
so we need, in terms of medicines, we need venodilators and we need diuretics.
Yeah.
So this is the support basically which we are giving to the heart indirectly or directly. Right? Here we are not talking about any mechanical support. I got confused whether you are talking about
No. I'm not talking about mechanical support. I'm not talking about mechanical support. I'm just asking, like any drug which is dilator as well, and it is an inotropic as well. Just like an inodilator, if we use in some patient, will it help?
We can, I think, but I think whenever there is a low BP, only when we can use inodilator, not in because this patient was already having high BP. The BP was 150 and 80, 90. So inodilator, probably rather than inodilator, we need diuretics and venodilators in this case. So we use those venodilators and diuretics.
Okay, thank you. No. The diuretics usually cause dyselectronemia. So as we give so many diuretics, is usually cause dyselectronemia.
So many low dose diuretics definitely help in COPD patients with scorpulmonale where the RR is dilated.
Yeah.
Definitely help in the
Inodilator
weaning
is
process.
definite, yeah.
Definitely
My question is only about at the time of weaning. It's not like for a long term, it's just like at the time of weaning.
Ma'am, weaning is a long-term process.
Yeah.
So, inodilator in the form of intravenous dobutamine or milrinone probably would help for certain period of time.
Yeah.
I would say anything which helps and supports heart failure, the oral medication which
Yeah,
helps
definitely.
the heart in 1 week time, 10 days time, 5 days time. So those medicine would definitely help. And in my practice, like we do the ROSD concept, that evacuation and keep the patient dry once you start the weaning of the patient. It's by default we keep the patient
definitely
dry.
I understand that. But if we see, like if a patient with an heart failure, and if we are trying to wean that patient only by the support of diuretic without giving any heart support, will the heart support be beneficial if we give an inotrop with that?
Ma'am,
Because
I would
BP, if we can come down on BP, we can increase our BP. If inodilator decreases the BP, that is my question. Because VBG definitely helps to assess what is the venous saturation of the patient. And I think during weaning, venous saturation is also important as much as the arterial saturation. Because if we give a sorry, I'm continuing it. Yes. So it's the ABG and VBG. Yeah. So if we want to wean the inodilator, we can use VBG with that, just in case. Only at the time in the ICU, not otherwise.
That's in case of only when your heart is having reduced ejection fraction.
Yeah,
means
but
heart functioning is less.
Yeah,
Then
but
only
if
you can tell this is a bedside test to do a ABG and VBG.
yeah, I understand that.
So
but
my take on that would be, I would be decongesting the heart and I would be giving treatment for the heart failure as per the prescribed treatment for weaning purposes. Now, for the treatment of heart, if the patient is having severity of heart failure, NYHA grade 4, grade 3, treat accordingly, but do not give inodilator just for the purpose of weaning.
no. I'm just asking about Dr. The example you give, that he was having a preserved VF with failure. That is the only question. Yeah. Okay.
Thank you, sir. Thank you so much.
I thank you, our esteemed chairperson and moderator, for such a thought-provoking discussion. And I request them to collect their mementos from the memento session outside Hall A.
Now we are moving into didactic lecture on the topic graphical clues to a troubled partnership. Asynchrony recognition made easy.
I would now like to invite our honorable chairpersons to kindly come up on the stage. Dr. S.K. Mathur, Professor and HOD Anesthesia, JNU.
Dr. Sarita Narsinghani, Critical Care Consultant, Fortis Escort Hospital, Jaipur.
Dr. Manish Mittal, sir, Consultant Intensivist, Gitanjali Hospital, Udaipur.
So now I would like to invite Dr. to deliver his lecture on the graphical clues to a trouble partnership. That is important. Asynchrony recognition made easy. Thank you.
Thank you, Chair. So, unfortunately, this presentation was to be taken by our very dear senior colleague and professor of anesthesia, Dr. Vikram Bedi sir, but unfortunately he could not come. So, I am taking this lecture on his behalf. So, topic is about the patient ventilator asynchrony, how to make the recognition easy. So, a patient who is intubated, most likely the reason will be respiratory distress, and the patient will be requiring some respiratory support. So, we are providing the respiratory support in the form of ventilator. Okay, so we are trying to set the ventilator in a form that the patient is getting adequate support. So we need to make a balance between the patient's demand and the supply by the ventilator. If that balance is made, then the ventilator will act as a support to the patient and the work of breathing will be decreased and the patient will get rest. If this balance is not there, then it will lead to asynchrony or desynchrony. And this is very common in ventilated patients in ICU. And when this asynchrony is there, instead of making the breathing easier, it will actually increase the work of breathing. Do we have the pointer? So as we can see from this diagram, so the reasons behind asynchrony, most likely it will be either patient's reason or from the ventilator reason. Okay, so patient reason can be the demand has suddenly increased because of fever, because of pain, because of metabolic acidosis, or the respiratory drive has increased, or the demand has actually decreased in the form of patient is sedated or okay, so the patient is sedated or the muscle drive is not there, respiratory drive is less, or the muscle weakness is there. Or it can be because of some ventilator issues, the circuit problems, there is a leak and there is a ventilator malfunction, or it can be because of the person who is handling the ventilator, the setting is not right, the tidal volumes or the respirator which we need to set is not right. So that is also going to cause asynchrony. And what it leads to is agitation, dyspnea, there is increased work of breathing, there can be autopsy in a COPD patient, there can be hypoxia, and lot of problems can happen, and ultimately it leads to increase in the duration of mechanical ventilation, and ultimately the survival is also decreased. So how to identify that? So we have to come to the basics of the graphs. Okay, so this is the most basic graph we all know. So we are having trigger, limit, cycle, baseline, so we all know this. So depending on these three things only, we can define the desynchronies. Okay, so there can be the synchrony can be of triggering desynchrony, flow desynchrony, or a cycling desynchrony. So if there is a triggering desynchrony, that means either the trigger is very high or trigger is very low. Flow desynchrony means either the flow is very high or flow is very low, or cycling desynchrony means cycling is either delayed or it is premature. Okay. So amongst these, the reverse triggering, double triggering, the ineffective efforts, all these things can cause extensive damage to the lung because there is high barotrauma or volutrauma associated with that. But that doesn't mean that we do not have to identify the other desynchronies. So let's come to the individual desynchrony. So first is the trigger desynchrony. So this diagram shows us the most basic trigger requirement of the patient. Okay, so here we see that there is a negative deflection, so trigger has happened and the ventilator has given you the breath. Okay, so this is what we always want: trigger, breath, trigger, breath, trigger, breath. Okay, if your trigger is too high, what will happen? The patient is trying to make an effort so that the ventilator gives breath, but because trigger is too high and the effort is not able to reach that trigger, the ventilator will not deliver the breath. So what will happen? The patient's effort will fail to trigger the delivery of mechanical breath, and that will be known as the ineffective trigger or a wasted effort. What are the reasons behind it? So it can be because of low respiratory drive or muscle weakness, or in cases of pathologies, most often it is seen in the patients of COPD where they are having auto PEEP. So this is how we identify. Okay, so this is an ineffective triggering in a pressure support ventilation mode. So this is the pressure, and this negative deflection is the effort made by the patient, but it had to reach this point. This is the trigger. So because this has not touched this line, that means the ventilator has not sensed that the patient requires the breath. So this becomes an ineffective trigger. The patient tried, but ventilator could not sense. Here again, the ventilator could not sense, then the patient made even more effort, and now the ventilator sensed it and it gave the breath. Okay, so these three were the ineffective triggers, and this is the effective triggers. Similarly, in flow, you will see a positive deflection, and here we see that these three are ineffective triggers, and fourth one was the effective trigger. So what is the solution of this problem? So you have to reassess your trigger, and you have to see whether your trigger is too high, then you have to come down on the trigger. This is in the flow graph again. You can see here that this is the flow versus time graph, and this is the expiration, and expiration should have gone like this, but we see a hump here. This hump is the effort made by the patient for the next breath, but it has not led to next breath. The expiration has continued. So this is an ineffective trigger. So these are the ways you are going to identify. If you are in a very advanced ICU and you can monitor your esophageal pressures, then you can detect the diaphragmatic triggering, which will give you an exact number of triggers by the patient. And if you can make such diagrams, then you can see here that this esophageal 1, 2, 3, 4, 5, 6, 7, 8 times the patient has triggered, but only 1, 2, 3, 4, 5 times the patient got the breath. So 3 triggers were missed. So that is how you can exactly quantify if you have the esophageal pressure monitoring. Now coming to a COPD patient. So what is the challenge in the COPD patient? So just the same graph. So this is the pressure in the system, and the patient is trying to make an effort so that it reaches this point and trigger happens. Okay. If the patient goes into severe bronchospasm, then the patient will develop an auto PEEP, right? So what is auto PEEP? The intrinsic PEEP is there. So your pressure will now rise from this point to this point. So this will be your intrinsic phase. The pressure has increased. Now what the patient has to do for triggering the breath? So it has to come from this point to this point. And just imagine a patient who is a COPD patient having bronchospasm, he is having LRTI, the muscles are weak, and now he has to make a double the effort to start the breathing. So it is very, very difficult for this patient. So the point here is that if you are seeing that a patient is in auto PEEP and a patient is a COPD, until your bronchospasm has totally settled, do not start weaning at all. Okay, so bronchospasm has to settle completely, then only you start weaning, because if you are going to start at this point, you will lead to failure of weaning, and ultimately all these things will add up. What is the solution to this? Just apply the extrinsic PEEP. So extrinsic PEEP will help in increasing this point to this point, and your effort will be decreased. So extrinsic PEEP is very, very important. What will happen if the trigger is too low? Okay, so let's see. So trigger is too low means the patient is not trying to trigger, but the ventilator is sensing that the patient wants the breath. So this is automatic triggering or auto triggering. Okay, so why this happens? So this happens when there is flow sensing and there is a leak in the circuit. Okay, so when there is a leak in the circuit, there is continuous flow coming into the circuit, and that continuous flow is taken by the ventilator as a signal for the trigger by the patient. So it is getting confused, right? So then it can lead to auto triggering, or because of cardiac oscillations also, there is a little bit flow movement is there in the circuit, and that is also taken as a trigger by the ventilator. Okay, so this is all causes of auto triggering. How do you identify? This is a classical diagram. You will see this is auto triggering. Lot of continuous respiratory breaths are there without any triggering. Okay. So main clear feature is unusually rapid respiratory rate. How do you solve this problem? You will obviously increase the trigger. Okay, and also eliminate the source of artifact. If there is a leak or there is there, then you have to remove it, and sometimes that is also not possible, then you can have to switch to the pressure trigger, because pressure trigger is not that sensitive as the flow trigger is. Coming to the flow desynchrony, so flow can be either very high or very low. Most often it will be very low. So what will happen? So this is a normal respiratory flow pattern. So this is a decelerating type of respiratory curve. And if we go into the ventilator graphics, in the volume control, we are using a constant flow, and in the pressure control, we are using a decelerating pattern. So out of this, these two, the pressure control has a more mimicking of our natural respiratory pattern. But we commonly are using a volume control pattern. So there is a little bit of mismatch already happening. This is the patient's requirement and this is how the ventilator is giving. Okay, so in a normal patient, it won't make a lot of difference and the patient will be good enough for breathing. But if the demand increases because of fever or pain or something else, and the volume has